they're statistically more likely to have complications, including a lot, prolonged, multiple, and adolescent pregnancies. Again, adolescents are usually, of course, not encouraged to be pregnant, especially if they are below 16 years old. To simplify it, do not be pregnant below 16, and as much as possible, don't get pregnant above 40. We need to say, of course, that is, of course, the rule, especially first pregnancies. Although the risk, of course, for that will be increasing as the mother's age progresses. Just like commonly some, of course, OB will gonna say, of course, that the high-risk pregnancy will be occurring if the first pregnancy occurs at the age of above 35. Okay? But your book says, of course, 40. And then again, the risk, of course, of pregnancy will be having a lot of complications in succeeding pregnancy, especially if the mother will be a grand multipara. So when we classify a grand multipara, these are the women, of course, who are pregnant on the first, at least 5 times. Okay? So again, our goal here, of course, will be, of course, always, each time the woman goes to the clinic, always assess the risks. Okay? You have only 2 things, low risk and high risk. There's no moderate risk. Okay? So we have to identify the problem because, again, identifying the problem or risks, we could address it right away and we could begin interventions. These are the 2 goals, of course, of prenatal or antepartum care. Right away, identify the problems if ever there is, and then again, begin, of course, interventions right away, or else there will be, of course, a lot of complications. Again, the complications will be to the mother herself, to the process of childbirth, or to the fetus that will be, of course, to the baby, of course, that will be given birth. Okay? So again, first one, of course, is that to check, of course, if we have some risks. So again, first one is diagnostics. So when we speak of diagnostics, what are these procedures, what are these studies in order to rule out that there is, of course, complication in the pregnancy? First one is amniocentesis. So in amniocentesis, we are inserting a needle, okay, into the maternal abdominal wall. The purpose for this one is to of course, withdraw a portion or a volume, of course, of amniotic fluid, okay? Amniotic fluid, as we know, of course, is the child's or the fetal, of course, side. So we need to say if we are getting, of course, from this amniocentesis, so most often fetal cells will be, of course, checked or will be captured, of course, with the amniocentesis. Okay? Some of this diagnostics, of course, some, of course, of the disorders that could be identified would be commonly, of course, to the fetal abnormalities. Okay? It can show, of course, certain cells or genetic anomalies that we're going to show the child might have developing Down syndrome. Okay? Usually why we have to know this one, because again, if the woman is at risk, we have to confirm that the baby is healthy. If there are genetic anomalies, okay, and this amniocentesis is done before, of course, the 20th weeks, okay, again, it will be, of course, presented because we are here in America, we have, of course, what we call as legal abortion, and we call that one as our therapeutic abortion, okay? So when speaking of therapeutic abortion, then it will be presented to the mother. Would you forgo for the pregnancy or not? Provided, again, legally, those, of course, termination of pregnancy should occur before the completion of 20 weeks. Because at 20 weeks, we know that the fetus is already capable, of course, of surviving outside. Therefore, it's no longer, of course, abortion. It's already, of course, infanticide. Okay? So Tay-Sachs, Tay-Sachs, of course, is a Jewish ascendancy. We call it one abnormality. Muscular dystrophy, known, of course, we know that, again, in muscular dystrophy, the most common is Duchenne's, okay? Wherein there will be ascending paralysis for the child. Cystic fibrosis, a problem with the GI tract, and probably the lungs, that we're going to make, of course, it will be harder, of course, for the child, of course, to grow older. And another one, of course, will be, of course, your spinal bifida. There are just only few, of course, of the genetic anomalies that occurs in the fetus that could be detected in amniocentesis. Okay? Amniocentesis is not without risk. There's always a risk. Okay? Therefore, amniocentesis, when we have to do amniocentesis, first thing before amniocentesis will be ultrasonography. A doctor cannot do amniocentesis provided we have to do ultrasonography first. Why? Because again, to determine the position of the baby, the location of the baby, the location of the placenta, and the location, of course, of the amniotic fluid. It is, of course, a mortal sin to puncture the baby with a needle. Or another one is that to injure the placenta, because any injury to the placenta or the baby could cause fetal distress. And because of that one, again, it will warrant, of course, we cannot prevent, of course, termination of that pregnancy. Okay? So high risk. So amniocentesis reveals, again, another one, LS ratio. What is LS ratio? LS ratio is not Lirios-Mayo ratio, it's not mine. It is what we call as lecithin sphingomyonin. Okay? Illness ratio, of course, tests for fetal lung maturity. As I have said, the balance, the ratio, of course, of lecithin and sphingomyelin should be 2:1. 2:1. Or, if what is the normal LS ratio? It's just simply 2. Again, LS ratio is simply 2. Or, if you want, of course, to be complicated, it should be 2/1. 2 lecithin, 1 sphingomyelin. That should be the ratio. If the child's, of course, system, of course, reaches that, that ratio, it means to say that the lungs is mature enough to take in air. Okay? Why this is very important? Because, again, if, again, there will be, of course, early termination of pregnancy, or shall we say it is a preterm birth. So again, we would like, of course, to push, of course, that the fetal lung will be mature, or else the baby will eventually die if the baby cannot breathe properly. Okay? So LS ratio is determinant, of course, of the fetal survival. Even the baby will be born premature. Okay? Are there a lot of things, of course, we can do? Yes, of course, later on, but we try, of course, to as much as possible, push the baby towards full lung maturity. And sometimes, we could check it with the amnion tests if indeed the baby's lung is mature enough to be delivered safely. Again, that is not without risk. But again, the target will be if sometimes there is, like, for example, if a woman, of course, didn't know their LMP, so you don't know when will be, of course, the 35 weeks, isn't it? 35 weeks is the age of the baby wherein we can reach the LS ratio of 2:1. Therefore, if the baby will be delivered prematurely, we want the baby to complete as much as possible 35 weeks. The purpose for that is only one thing. We want to reach, of course, fetal lung maturity. If it is not reached, the baby might die with respiratory distress. Okay? So that's one. And again, 35 weeks will be the age of the baby we can reach fetal lung maturity. Therefore, if we deliver, of course, a baby before 37 weeks, which is a premature delivery, we want it to be completion, of course, of 35 weeks. Sometimes it cannot be done because sometimes at 32 weeks, we cannot prevent, of course, the birth because, of course, of a lot of conditions. We're going to talk about that later. Determines the status of the RH positive fetus in an RH negative woman. The purpose for this one sometimes is to check, of course, if indeed we might already have antibody that is trying to kill the baby. Okay? Again, RH negative mothers who are pregnant with the RH positive babies, of course, if there's of course, an accidental influx of blood of the baby towards the mother will develop antibody against RH factor. In amniocentesis, we could gather some cells from the baby and check if indeed we have already, of course, the presence of maternal antibodies against RH. Because again, that will be the time that we have to closely monitor the baby. Believe it or not, even it is with utero, most often that's the most common cause why the mother's body is killing the fetus inside. Okay? So eat well. So that's why sometimes later on we could do something about it. Although it's a very complicated form, of course, of pregnancy. But again, we want to know. Again, and because of that one way to do that one would be, of course, to prevent, of course, maternal exposure to the baby's blood. If we sometimes we cannot avoid it because of probable, of course, possible exchange during, of course, injury, then we have, of course, to administer, of course, a vaccine to prevent sensitization, of course, of the mother system. Okay? Intrauterine growth restriction, IUGR, especially for those babies, of course, who are small for gestation or very restricted or in the same malnourished. It must be a small for gestational age. And commonly, babies, of course, that are small for gestational age will be maternal factors, just like maternal malnutrition. But sometimes, commonly, it might be, of course, always, of course, there is intrauterine growth restriction. Most commonly, of course, that occur, of course, in the normal form of pregnancy is that when the pregnancy is by twins, okay? If they are especially identical, if they're only sharing one placenta, they compete with the maternal resources. If that will be the case, sometimes the baby will be small, okay? And again, to tell you as a matter of fact, when the woman, of course, is pregnant with a twin, most often the twin will be delivered premature. Clear? Because the uterus is only, of course, built or designed only for one baby. If there are two babies, the uterus cannot support the needs of the two babies. That is why most common twins, of course, or two babies inside, of course, will be sold to not completing the 37 weeks. Therefore, it's always premature. Yeah?
So would the triplets would be much sooner than that?
Much sooner than that. Say, how much more if it's 8?
Yeah, I'm curious about how soon do they deliver baby if it's that much?
Again, the answer we're gonna go back when will be, of course, the baby will be of course able to leave.
So they all past 20 weeks after that, they can
Correct.
be delivered.
But again, we don't want, because at 20 weeks, believe it or not, of course, chances of survival of the baby is less than 20%. If we move 21 weeks, it will gonna increase, of course, by another 20%.
Yeah, but there's a point that they cannot go past, right?
So again, that's the question I would like, of course, to go back to you. When is safe delivery, of course, of a baby that is 8 inside, or just like Octomom? Okay? So is it a high-risk pregnancy, if I'm gonna ask you? Very complicated pregnancy, is that. When do we deliver the baby? Answer me. When do we deliver a baby that's 8 inside? First one, we want the baby to be delivered above 20 weeks. You're right. Why? Because it's the only time, of course, that the baby are viable. Okay, isn't that? But we don't want it to be, of course, just exact 20 weeks. Okay? Now the question will be, if not the 20 weeks, okay, when is the right time, of course, to deliver the baby?
What, 35 weeks?
37 weeks, 35.
There's eight, just like, of course, a mother pig. Of course, there's 8 there. And then, again, the normal uterus, of course, of a woman, especially a human, could only support 1 baby. There are 8. So the question will be, when will be, of course, expected, of course, to deliver the baby? Until when?
If it's just one baby?
8. We have 8 inside.
Well, he said, one is 20% and 21. You know,
But again,
21
technically, of course, we could deliver the baby as early as 20 weeks. At 20 weeks, baby could leave. But the question is that we don't want it exactly to be at 20 weeks old. Okay? Now, the question will be technically when? Until when could we still keep the baby inside?
28.
This is not the question. I want an objective answer. When, until when could we keep the baby inside?
Long maturity.
Is that even reaching that point?
Till the water breaks.
Huh?
Till the water breaks.
Nope. That's normal pregnancy. What will be the right answer?
Well, that would be any time above 20 weeks.
Correct. But again, the word specific, until when we could keep. What is the most common objective thing that we have, of course, to check? That will be the time, of course, probably to deliver the baby. Because why? And until when?
Less than 20.
What will be the most objective data that we could keep the baby still inside if we could? I don't care, of course. Again, this age will be 20 weeks at least. Okay? There's no question about that. But until when? Because I don't want to deliver the baby at 20 weeks as much as possible. Big survival rate for the one is a little bit low. I want to keep the baby, and so that again the chances of survival outside will be a little bit higher.
Is it? That's just a guess.
Mhm.
Until like, does the amniotic fluid
Yeah,
does
yeah.
does it go away like eventually or
Amniotic fluid doesn't go away.
it doesn't? Does it get smaller?
The dry birth, of course, or dry delivery is a myth. Until the baby, until the placenta is adhering, of course, to the wall, amniotic fluid, of course, will be still produced. Although, after 40 weeks, the volume of the amniotic fluid decreases.
It's just
Decreases. But it's that. The dry labor, of course, is a myth. Okay? So my objective thing is that until when we could keep the baby.
If another baby's like in distress or if you don't hear
Not
anything
only
on
baby,
its own,
when one or
One
all the
baby
babies
is
is in, define distress,
like
Shirley.
if you don't hear fetal heart tone.
Correct.
Or if you don't
That's
blood
very
pressure,
specific. Decreased variability.
decrease.
Mm-hmm. What else? If the fetal heart rate, of course, changes, of course, from below 100, either one or two of the babies. Therefore, one of the objective data, of course, until we can keep the baby, as long as we don't have any fetal distress, keep the baby inside. But if shows that there is fetal distress, decreased variability, late deceleration, variable deceleration, then we have to deliver the babies. Because again, the baby will die, in a way. Clear. So the objective data when, the answer will be until there's no distress to the baby. If there's distress to the baby, after 20 weeks, we have to deliver the baby. We don't have any choice. Because the baby will die if we want. Okay? So the answer to your question, until such time that there's no distress. Once the distress shows, one of those, variable deceleration, variable deceleration, or decreased variability, or late deceleration, those are the 3 that will get changed, of course, in the fetal heart rate. And fetal heart rate will be a very important tool to monitor what is the status of the baby inside. Then that will be the time, of course, we have to deliver the baby. So technically, of course, what did it, barely, of course, it can reach 30 weeks. because of the volume of pregnancy. Okay. Very good question. Instruct the client, of course, to empty her bladder amniocentesis. Again, amniocentesis empty the bladder. But again, before that amniocentesis, we have, of course, to check where's the location of the baby, where's the location of the placenta. We have, of course, to do an ultrasound. Ultrasound always precedes amniocentesis. So we cannot do amniocentesis unless we do ultrasound, okay? Monitor the woman's vital signs during the test and for at least 1 hour afterwards. One important thing, always monitor your fetal heart tone. Your fetal heart tone will tell you is still the baby alive inside. Clear. Therefore, your responsibility until the baby didn't get out yet, of course, from the mother's womb, monitor the fetal heart tone. That is your only clue if the baby is still okay inside. That is why we have an acceleration, or which is the fetal distress, as I have said. Technically, of course, 60 above, of course, the baseline heart rate will be distress. Below 100 is distress. So we have to monitor the fetal heart tone. That's the only way you could check if the baby is still okay. And again, remember, until can we keep the baby, the bottom answer for the one, until the baby is still within the parameters inside. If there is fetal distress, we don't have any choice. We have to remove the baby, whatever, of course, whatever way it will be, whether it be cesarean section, it is vacuum delivery, is it, of course, a forceps delivery, whatever that will be, as long as we could keep the baby alive. Okay? So that's it. Because again, here, there's, of course, because of that one, anything could happen. Abruption placenta, it could be. Accidental puncturing, of course, of the baby, it could be. It will going to lead, of course, to only one thing. Okay? And that thing will be fetal distress. Instruct the woman to deliver that pretend if she has difficulty in returning home, including any bleeding. A bleeding, of course, again, is a complicated thing, of course, even after amniocentesis. Okay? Ultrasonic scanning, ultrasound. Again, usually we use this one, of course, before amniocentesis. But again, usually we do that one between 16 to 20 weeks. Okay? There's a lot of things. First one, if the woman didn't know, of course, when is the LMP, that will be the time you can now technically, of course, age the baby. Or what is, of course, the age of the baby, gestational age, the fetal head size. Fetal head size is very important because, again, why? We have to compare that one later on. Again, it could be one, early hydrocephalus inside, or another one, is it, of course, still feasible, of course, to deliver that fetal head, of course, in the pelvic inlet, so that we don't have any problem. Location of the placenta. Location of the placenta is very important, especially if we are doing amniocentesis. Okay, some of the fetal abnormalities. Again, bottom line for this one, if it is done at 20 weeks of gestation or 20 weeks age, okay, of the baby, then we could determine what is the sex of the baby. Okay, which is just a bonus. But again, fetal abnormalities such as only one kidney, the chambers of the heart are only 3 except of 4, okay? So those are the things, of course, that we could check. Is there any spina bifida? We could also check, of course, with the ultrasonography, okay? So those are the things, of course, we could check. But bottom line, the purpose, of course, of ultrasound, of course, especially before amniocentesis, is very important to locate every fetal parts, placenta, and amniotic fluid. But therefore, the question will be, how would the doctor know where to put or to insert, of course, the needle? They have to locate all the parts by ultrasonography first before. And ultrasound, the most important preparation, of course, will be the woman has a full bladder. Okay? And please make the woman that full bladder is necessary to test. Meaning to say, in amniocentesis, the woman has to pee. So this is usually what we are doing. Ultrasound first. Once we locate the fetal part, again, with the ultrasound, before the ultrasound, we are giving water to the woman. Drink, 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 drink until we have a full bladder. And then with the woman's full bladder, then we do ultrasound, we locate everything. Once we locate already everything, we ask the one, okay, you urinate. After the woman urinate and returns back, of course, usually we could do this one, of course, after the woman returns, that will be the time that we could do amniocentesis. Before ultrasound, full bladder. Amniocentesis, empty the bladder. Okay? We don't want, of course, to have injury in the bladder. Yes?
So this test, it to be done for everyone, or it's just done for who had a history or something?
To take a look, of course, what I said. Why we have, of course, to insert the needle for the amniocentesis. If, again, we're talking here, of course, if we have high-risk pregnancy. Okay? We don't just do that one right away there and then. Okay? If the risk is very high. Would you like, if you are pregnant, if there's no indication, would you like, of course, for a needle to be punctured in your tummy? That's why.
No, I understand high risk, but when I was reading, there is a many type of high risk. So
There's
each
only
for
one. only high risk is high risk. I have only one high risk, and that is high risk. Meaning to say you are entertaining possible, of course, complication of pregnancy. That is high risk. That's the definition of high risk. There's no other high risk. There will be a lot of complications, there will be a lot of problems, therefore the pregnancy is high risk. Okay? So if you are pregnant and you don't have any problems at all during the pregnancy, normal spontaneous pregnancy, that is low risk. But if of course a problem arises, that's already a high risk pregnancy. There's only one that is a high risk. That's why I said there's no such thing as moderate risk of pregnancy. And again, I'm talking right now is that a woman that has a problem with the pregnancy. Therefore, I'm talking about high risk pregnancy. In normal pregnancy, did they talk about amniocentesis? Therefore, it is not clear. Why is that? Of course, we have to do, of course, this 1 to the 1 because we want to know is what is the problem, but is the extent of the problem. And barely because that's why, because the risk, even of course, for amniocentesis is very high. Okay, puncturing the baby, puncturing the placenta, that will lead, of course, to premature birth of the baby. It's very, very high risk. But sometimes we have to know in order, of course, to know the management. Just like amniocentesis, why is being done for high risk, of course, pregnancy? Because again, why? For only one reasoning. If you are pregnant, you are here in the United States of America, just think about this one. If it is done before 20 weeks, amniocentesis, okay? Now you know that you have a Down syndrome. The question for you, of course, as a woman will be, would you forgo the pregnancy or not? Now, based, of course, on your culture, based, of course, on your faith, so probably you don't agree with the abortion, but again, here, an option, of course, here clinically, of course, in the United States of America is that if the baby is high risk, it's complicated and has abnormality, you will be given a chance because that's by law. Okay? You will be given a choice. Would you like, of course, are you okay to terminate that pregnancy? Because, just to tell you, a lot of cultures, of course, say no. But there's a lot of women, of course, who will just say yes. Just think about it. If you have a child, of course, who have spina bifida that will eventually, of course, you're gonna raise, okay? Or a Down syndrome, that is a lifetime responsibility for the parents. Do you think you will be not burned out, of course, to take care of the kind of baby? That is why options are being given. At the end of the day, it will be the woman who will still be, of course, deciding if she will forgo the pregnancy. Okay, clear? So that's the reason why I'm talking about this amniocentesis. It is not normal pregnancy. This is high-risk pregnancy. Okay?
I got a question.
Go ahead.
After the ultrasound and the fetal parts is all located and placenta is all located, is the needle always pass through the belly button or the depends?
No, it's not. Not necessarily, of course, the belly button. It
So
depends
depends
where's
on
the
the
location, of
location,
course,
right.
of the amniotic
So
fluid.
it could be anywhere within this. Okay.
That is the purpose why we have to do. We are ready to do, of course, ultrasonography. Not the belly button.
Okay.
If the location, of course, depending on the presentation of the baby, didn't have to locate. That's the main reason why. And you don't want, again, three things, of course, you don't want to puncture with the needle. Placenta, the baby itself, even umbilical cord. You don't want to puncture umbilical cord unless otherwise you are trying, of course, to do, of course, a peri-umbilical cord sampling. That you need, of course, later on for specific blood typing of the baby.
That's the reason why I was reading about it and I thought they always said it goes through the belly button.
It could be, it depends on the location, but again, it could be varied. The question, of course, that's why the question, of course, to answer the question of where the doctor will insert the needle, ultrasound it. Okay. So again, ultrasound will be only 20 minutes, and again, that's not invasive because we have on to have to do a gel, okay? To do a gel, and this is invasive, and later on we will know. And usually it's a bit of progress, of course, that each time the woman go to the prenatal, doctor either going to check on the ultrasound, or it could be a Doppler, okay? A fetoscope with a Doppler to check, of course, where's the fetal heart rate, okay? Another one is your oxytocin challenge test or contraction stress test, okay? Evaluates the response of the fetal heart to the contraction. Nipple stimulation, there are two things a lot, okay? How would you cause, of course, the uterus, of course, to contract? It could be nipple stimulation, we could do that one, or sometimes the most common one, we are giving, of course, a small dose of oxytocin, okay, to the woman in order to jerk the uterus, okay? Reaction of fetal heart determined using, of course, fetal monitor. So meaning to say, the purpose for this one is that, the question is that, how does the heart of the baby reacts when, of course, the uterus contracts? That's typically, of course, your contraction stress test, okay? There are two things, contraction stress test, and then later on is non-stress test, okay? Information provided here is this is a question that's being provided. Is still the baby okay? is the placenta and the uterus still okay and can still support the need of the baby? Because the data that we're gonna see here is that, again, is still the baby healthy, and is still, of course, the placenta. The question in also the challenge test or contraction stress test is that, is uteroplacental sufficiency still present, or is not able, of course, to support the need of the baby? Okay, so classified as positive persistent late deceleration with more than 50% of the contraction. Okay, so usually what we do, of course, is that stimulate again in a 10 to 15 minute period. Of course, we have, of course, to have, of course, at least 3 contractions. Okay, and in the 3 contractions, 2 of them it result in late deceleration. When we speak of late deceleration, meaning to say the uterus contracts. After the peak of the contraction, the acme, then you can see, of course, the changes, of course, of the fetal heart rate. Late deceleration, meaning to say that the heart rate of the baby decreased. Okay? We don't want it to be decreased, of course, with 100, but again, at least there's a decrease, of course, in the fetal heart rate. If that will be, of course, persistent late deceleration more than 50% of the contractions, the answer is yes. Again, the question in contraction stress test is, do we have, or shall we say, is the placenta and uterus still able to meet the supply of oxygen? Okay? So that's the question. If there is, of course, 50% of contraction, it means to say yes. Of course, it means, of course, to say, of course, that the uterus and placenta, of course, cannot support. Okay? This is just made about continuing the pregnancy or performing C-section. Again, why? If you allow the baby, of course, to be there inside still, and the uterus and the placenta is not enough to support the needs of the baby, there will be a lot of abnormalities, of course, that will going to occur to the baby. One of the most common one is fetal anoxia. Okay? And fetal anoxia will going to lead into a lot of problems, either brain damage, or the most common one, of course, will be it will going to cause, of course, the baby to relax. Okay? To relax the anal sphincter and to allow meconium to go pass out. And it will going to cause, of course, meconium staining. Okay? So although the OCT is not dangerous in itself, it may stimulate labor. Therefore, it is generally performed in the labor delivery area rather than in the clinical setting after the fetus is viable. Therefore, do not do a contraction stress test below 20 weeks of gestation, or else it might cause spontaneous abortion. Okay? So again, the question: what is now? Tell me, what is a positive what is the positive oxytocin challenge test? What does it mean to you?
To make sure that
Again, explain to me positive OCT. How do you understand positive OCT? Do we have a problem or none?
Yeah. Heart rate.
If there's a problem, what is the problem?
Deceleration. Heart
Heart
rate
rate
probably
decrease.
decrease or
That is
increase.
only to determine if we have positive or negative. My question will be with you is that we have a positive oxytocin challenge test, or we have a positive contraction stress test. Do we have a problem, and what is the problem? If ever there's a problem.
Heart contraction probably.
Nope. I want to push the bottom line. I want to simplify the concept, or else you cannot get it again. That's why I'm asking this question.
Because
Now,
there's late,
Now the question will be, if you are doing an OCT, what kind of result you wish and you want to get from the mother? Negative or positive? You are doing an OCT with the mother, okay? In order, of course, to have no risk or low risk pregnancy, you want the OCT to be very good. You want it to be negative. No deceleration at all. It means to say that, what does it mean? The uterus and the placenta is still good enough to support the oxygen needs of the baby. Now, if the result will be positive, do we have a problem?
yes.
That's a high risk pregnancy. What is the problem? Correct. Meaning to say that
It happened more than
we cannot keep the baby because the uterus or the placenta is not capable of meeting the oxygen needs of the baby. Letting, of course, the baby to be still there inside, it means that it could kill the baby. Therefore, the answer will be, we don't have any choice. Do an OCT, then OCT shows we have positive. Therefore, we don't have any choice. Get the baby out from there, or else the baby will gonna die. Clear? Positive OCT will answer one thing. We have to take out the baby, whatever the method will be. And most commonly, it is C-section. Okay? Why? Because if we're going to allow the baby to be there, then the baby will die. Clear? That is your OCT. And you wish it to be negative, no positive. Positive is abnormal in OCT. Clear? Simple. Okay. Non-stress test. Okay? Don't confuse this one because I would like, of course, to point out, of course. Non-stress test here provides information of fetal heart rate in response to fetal activity. Now, when I speak of OCT, the question will be, what is the status of the uterus and the placenta? That is, of course, an oxytocin challenge test. Here, the question will, and again, but the data that you're determining there, of course, in OCT is fetal heart rate also, isn't it? And relative to the contraction. Now, here, in non-stress test is, of course, you're monitoring the fetal heart rate, but you're comparing it, of course, when the baby moves. Therefore, our goal in non-stress test will be, usually, to stimulate the baby so that the baby will gonna move. Each time the baby moves, you want to know if indeed the fetal heart rate increases. Just like when you go in the treadmill, you go jogging, does your heart rate increases? We want to know. It means to say that only shows that if the baby's heart rate is increasing, it means, of course, that the baby is already able to adapt to stress, to adapt to movement. Clear? Okay? So again, so external fetal monitor, the purpose for the external fetal monitor will be to monitor the fetal heart tone. Okay? So perform about 28 weeks, usually later, of course, than OCT. Okay? 28 weeks of gestation. Now, at least 2 episodes of fetal heart rate acceleration. Here now, we are checking, of course, for acceleration because a healthy heart of the baby will accelerate, of course, of around 15 beats per minute if the baby is moving. So each time, of course, the baby kicks or moves inside, okay, usually, of course, the heart rate, okay, if it is at least lasting 15 seconds within the continuous 10-minute period. Okay, how do we know that one? Usually, what we do is that each time, of course, the baby moves, the mother feels it, the mother press the button, okay? So when the mother press the button, we have to check, of course, if there's an increase in fetal heart rate because the woman will know indeed if the baby is moving or not. So each time the baby moves, press the button. We have to check if when the woman press the button, with it is synchronized, of course, in fetal movement, we want, of course, to know if there is an increase in heart rate. Okay? Fetal heart rate increases with every fetal movement. It means that fetus is doing well. Fetal heart is very healthy. Okay? Therefore, we want, of course, a negative OCT and a reactive NST. Why? If the baby, of course, responds, it means to say, of course, that the baby is healthy. Therefore, later I don't want you to confuse that. Positive OCT equals?
No,
Yeah, that's correct. A problem. Positive NST equals?
that the baby's not doing good.
So we want a negative OCT and a positive NST. Clear? That's the difference. Because a positive or a reactive NST, it shows that the fetal heart is healthy enough to compensate with its movement.
Negative OST.
Well, what are you talking about OST? Read it properly, Amani.
Say negative OST, right?
Why? Do you want a positive OCT?
No.
So what is your wish? What is your goal here? As much as possible. The normal will be negative OCT and a positive or slash, also known as reactive NST. That is your goal. Okay. If the NST is non-reactive or negative, it means that we call that one as short decreased variability. It only shows one thing: fetal distress. Clear? Okay. How do we stimulate the baby? Fetus may fail to be active during the course of the test, especially if the baby is sleeping. So we want to wake up the baby. Hey, wake up, baby. We palpate, of course, or shaking the uterus. And sometimes we make loud noises because, again, why? The baby inside could hear. That's why it is true, of course, to talk to the baby during pregnancy. Even the mother reading, of course, stories or listening to classical music during pregnancy, the baby, of course, is proven, of course, there's a documentation for that one study that it enhances, of course, cognitive capacity of the baby. Okay, that's why when you're pregnant, it's good, of course, to play classical music for the baby. Okay? And it's always good, it increases the bond between the mother and the baby if the mother is talking, of course, to the baby. Could the baby hear? Definitely. Believe it or not, sense of hearing is the first sense we develop. In the last one we lose when we die. Clear? Okay. stimulating the woman's nipples in order, of course, to create, of course, a little bit of contraction. That will be another thing. It means, of course, that touching the mother's nipple during pregnancy is not healthy. As a matter of fact, it's a part, of course, of the test. Okay? Another one is that fetal biophysical profile or other tests, FBP, combines NST. And in fetal biophysical profile is a lot, of course, of series of tests. It is, of course, a score, of course, of 0 to 10. One component of it, of course, will be your non-stress test. If the baby, of course, reactive, usually we put 2. Okay? So if you score it with 2, then the rest of other things, of course, will be scored. We want, of course, the score in fetal biophysical profile or FBP to be around 8 to 10. Okay? 8 to 10 score, of course, in here, it means, of course, that the baby is very healthy. Fetal biophysical profile, usually we download it with ultrasound, fetal assessment, ultrasound, NST, and a lot, of course, of other things. Then it only shows, of course, that the baby is healthy enough or not. Okay? The score that we want, of course, to be specific, will be 8 to 10. Other tests, percutaneous umbilical blood sampling. This is being done again through like amputation tests. But again, the only thing for that one is that we target, of course, directly when we insert the needle. Okay? We want to hit, of course, the umbilical cord. The purpose for that one is sometimes to get, of course, a sample of the blood of the baby. Okay? Sometimes we could hit, of course, the chorionic villi sampling. We could do that one too. Okay? Sometimes maternal serum or alpha protein will be, of course, done. For these two, what we need, of course, is fetal tissues. Especially in the PUBS, we want blood of the baby. In maternal serum alpha protein, in amniocentesis, we could do, of course, your alpha fetal protein or AFP. But here in maternal serum alpha fetal protein, it is the mother's blood. Okay, these are some tests to make sure, of course, indeed, of course, that we have abnormality, just like, of course, the problems, of course, with spina bifida or neural tube defects. Okay. Again, I would like to highlight percutaneous umbilical blood sampling. Sometimes, not only blood sampling. Would you believe, of course, that sometimes in the most complicated pregnancy, not only that we have only, of course, to insert a needle, we have to insert a catheter through and through, of course, to the umbilical vein. Okay? To the umbilical cord. You know why? Sometimes we need to change the baby's blood because the baby's blood are already all hemolyzed, especially if the woman's system, if the woman is usually sensitized with RH. Usually the antibody is coating the baby's blood, and again, it's killing the baby's blood. If all the baby's blood, or more than 80% of the baby's blood, of course, will be destroyed by the maternal antibody, the baby will die. So the last recourse for that one, because we cannot deliver the baby, because when we deliver the baby's survival will be low. It might be, of course, only around 20 weeks. Okay? So sometimes in that kind, of course, of complicated pregnancy, we can insert, not only PUBS, we're inserting catheter directly, of course, to the umbilical cord. And we have to do what we call a SURE, intrauterine blood transfusion. What we are doing here, we are transfusing blood to the fetus inside. Could we do that? Yes, we could. That is usually, of course, the last recourse sometimes to save the baby. The baby is still inside, but so we need, of course, to do blood transfusion because there is not enough functional RBC, of course, to the babies or the fetal circulation. Okay? So PUBS is just that's the elementary, of course, part of the kind, of course, of complicated pregnancy. Okay, now, any questions for that? Those are the diagnostic tests that we do, of course, to make sure, of course, that the baby is okay or not, or if the baby is not okay, how bad is the baby is. Okay? Now, a lot of problems, of course, with pregnancy. First one, pregnancy interrupted. Okay? Or interruption of pregnancy, therefore we call that one abortion. Abortion versus pregnancy. Again, abortion occurs only for the pregnancy ages below 20 weeks of gestation. Again, the term, of course, of the baby that died in uterus, okay, before delivery, if the age is 20 weeks above, we call that one a SURE. Well, what do you call, of course? No. Baby died before delivery, age of gestation above 20 weeks of gestation. Stillbirth. Okay? Below 20 weeks, abortion. Again, don't tell me, of course, that's why, of course, in our gynecological scoring, so it can never be, of course, the woman's, of course, abortion score in the P will lead, of course, to a living child. nobody, of course, that we know, of course, that is aborted or an abortion that eventually, of course, become alive. Okay? Because again, by the mere thing, fetus is not viable yet below 20 weeks of gestation. There are two categories, of course, of abortion. It is, of course, spontaneous, meaning to say it happened. When we speak of spontaneous, it occurs, of course, naturally, commonly. It is spontaneous, okay? Without medical intervention, that is caused, of course, as your natural causes. Okay, spontaneous without medical intervention, nothing happened. Only it is a natural. So sometimes we call that one as your miscarriage. So the term miscarriage usually, of course, we don't use that one technically. But miscarriage, of course, is being used, of course, by laymen. Okay, so ordinary people when they say, "Oh, I got a miscarriage," okay, because abortion, of course, sometimes a negative connotation. Okay. Another two, spontaneous, and the other one, of course, is your induced or therapeutic. Induced abortion with medical intervention by the way of mechanical assistance or medical agents. There are a lot of things to abort it, either the physical means or another one, of course, will be chemical means. Okay? Some medication are called abortifacient, meaning to say it could cause abortion, especially if given to a woman with an age of gestation below 20 weeks of gestation. Okay? So spontaneous, it occurs, of course, around 10 to 20% of all pregnancies. Again, the major reason why there is abortion is not, of course, usually on the maternal side. The major cause why a fetus is aborted by the mother's uterus because of the fact that, number one reason, the fetus is very abnormal. Okay? So again, you always present this one to women who had abortion. Okay? Not only habitual abortion, but if the uterus decides, of course, to reject the baby inside it, it means to say that most commonly, the baby, of course, is very abnormal. And again, the uterus, believe it or not, as I have said, the uterus has a mind of its own. And you have to respect it. Meaning to say, if the uterus let it go, okay, it means to say it's very abnormal. And that's the most common reason why there is abortion. Again, I'm talking about spontaneous one that occurs naturally. Sometimes, if the maternal environment or maternal habits, of course, could present, just like, of course, maternal alcohol use, it could cause, of course, abortion because, again, it causes, of course, a lot of abnormality. The worst thing is that with maternal alcohol, the baby is kept. Therefore, of course, the baby could suffer alcohol syndrome, fetal alcohol syndrome, which could lead, of course, to a lot of other abnormalities. Okay? Cigarette smoking, maternal disorders, just like a lot. CHF, maternal heart problems, or it could be, of course, a lot of other infections, trauma. Vehicular accidents could lead, of course, to abortion. And there's nothing we could do with that one. Dietary factors. Again, if remember, of course, is that the best way, of course, to meet the nutritional requirements, of course, of both the mother and the baby, of course, during pregnancy will be to support them as well. Because, again, the woman is eating for two, okay? Or providing resources, nutritional resources for two people, the baby and hers. In the event that there will be, of course, a competition, meaning to say, nutrition-wise, there's only lesser that cannot be provided for both. The mother system will going to save itself. Therefore, it will reject the fetus, going to cause abortion. In that, of course, scenario. Okay? Or another one is that abnormality to pregnancy. It might be structural abnormality with the uterus, with the cervix itself, or it could be, of course, a lot of other abnormality, of course, surrounding, of course, the pregnancy itself that will going to cause, of course, your abortion.
What would the maternal disorder include? Would like a sickness, diseases or something for the maternal?
Yes, it could be, of course, there will be a lot. CHF, usually, of course, the maternal heart cannot carry, of course, the pregnancy. Therefore, the tendency, of course, of the maternal body, the maternal system, will going to, of course, save itself.
Diabetes and all those.
It could be. It could lead, of course, to spontaneous abortion. There will be a lot of hypothyroidism, or especially a lot, of course, of your endocrine disorders, of course, for the mother. Okay, so it would be, of course, a lot of other coexisting comorbidities or existing problems with the woman. So spontaneous, these are the terms that we use. Threatened. Condition exists anytime bleeding or cramping occurs in the first 20 weeks of pregnancy without major cervical dilation. Okay? There might be, of course, some spotting. Okay? Sometimes, if there's spotting before the 20 weeks of pregnancy, it could lead, of course, to possible abortion. We call that one threatened. Okay? The key factor there is that, the most common one is that the doctor will gonna do transvaginal ultrasound during this period. First one is to make sure that, again, cervix is closed. Sometimes if cervix is closed, usually we could still save the pregnancy. The most common one is that if a woman is spotting before 20 weeks of gestation or any part, the first thing that we have to do is that complete bed rest right away to allow the woman to walk. Okay? CBR, as a matter of fact, it's CBR without bathroom privileges. Sometimes we could do one because again, each movement, because of gravity and movement, could produce, of course, more contraction of the uterus. Spontaneous, of course, contraction that will lead to complete evacuation of the, whatever, of course, inside, of course, the uterus could be reached. That's why bed rest right away. So this one here, threatened, it could be saved, it could be not. But sometimes, when we speak, of course, of threatened, yes, most often we could save the pregnancy. Okay? Because again, why? What bottom line is that? Cervix is still closed. Okay. Complete abortion, it means to say, of course, that occurs when a woman spontaneously expels all the product of conception. Again, when I speak, of course, of product of conception, two things. What are the products of conception that we are talking about? The fetus? Correct. So this should be, of course, complete evacuation of that one. Most common, the fetus will be expelled properly. But commonly, the most common problem is that the placenta might not be. The worst case, of course, for that one, the complete abortion is that everything comes out. If any fragment of the placenta is retained, we call that one as your placenta accreta, or retained placental fragments, it will kill the woman. Because again, why? It will gonna cause bleeding. That's the reason. Or otherwise, septic abortion, contents of the uterus becomes infected during or an abortion, and when the uterus becomes infected later. Septic abortion could occur, of course, for those abortion that occurs, of course, without aseptic practices. Most commonly, this could be found, of course, in spontaneous abortion that is not complete. Or another one is that abortion that is done illegally in an environment wherein it's not aseptic. Okay? So septic endotoxic shock may occur and may cause maternal death. Again, septic abortion, meaning to say, of course, the uterus was infected after an abortion. It could be an incomplete, or it could be, of course, a spontaneous one, or it could be, of course, a complete abortion, but still, it is done, of course, or therapeutic abortion that's done probably, of course, in a scenario wherein, of course, it's not aseptically controlled. Okay? So, another one is recurrent spontaneous abortion known as habitual abortion. Why is the woman, again, first pregnancy, abortion. Second pregnancy, why is aborted again? So meaning to say, if there's spontaneous abortion, back to back, or two abortions, the question will be, it might not be the uterus that reject that one. It might be that the uterus is not capable of holding the pregnancy. And the one that holds the pregnancy always will be the cervix, the neck. When the woman, of course, when the woman is pregnant, the cervix has to close, isn't it? If it is open, it will let go, of course, of the weight of the developing embryo in the inside. Therefore, it has to close. Okay? Here in habitual abortion, the most common problem is incompetent cervix. An incompetent cervix is an abnormality, of course, that results, of course, when the cervix is incapable to contract or to hold the entire weight of the pregnancy throughout the proper term or the entire term of pregnancy. What causes this one? It could be the woman has cancer there before. The most common, of course, physical cause for that one is that the woman, we remove, of course, a portion of the cervix for the purpose of cervical biopsy. So conization, of cervical conization, could lead, of course, to a weak cervix. So a weak cervix, of course, eventually could lead into habitual abortion. Okay? So premature cervical dilation, also called incompetent cervix. Cervix is unable to support the pregnancy. Cause of premature cervical dilation. And again, if the cervix is dilated, we call that one as your inevitable abortion. Meaning to say it will gonna happen whether you like it or not. So the answer for this one commonly, of course, and again, when the cervix is dilated, again, infection could ascend into the woman as well as into the baby. And again, if it happens, of course, to the fetus reaching before 20 weeks of gestation, then it will destroy the baby, but commonly not only the one, it could leave infection, of course, on the maternal side of the uterus. Okay? That's one thing. So sometimes the question will be is that if you have the kind of course of cervix, do you still stand a chance, of course, to get pregnant? The answer, of course, will be yes. Okay? But again, before that, these are the causes. Cervical or vaginal cancer that weakens, of course, the structure of the vagina as well as the cervix. Previous cervical biopsy as conization, meaning to say, when we speak of conization, we cut a portion of the cervix, making, of course, the cervix a little bit weaker. Okay? Prior multiple dilation and curettage, so meaning to say, DNC is the most common thing, of course, that one is that we dilate the cervix and we insert, of course, a spoon-like curette, okay, in order to scrape scrape, of course, the entirety, of course, of the inner lining of the uterus or the endometrium in order to remove, of course, any products of conception that might be there in order to complete, of course, the abortion process. Okay? So DNC, of course, could be done prior DNC, meaning to say dilation. Anything mechanical, of course, disturbances of the cervix could cause possible incompetent cervix. That's why, again, or another cause is that first pregnancy successfully delivered without, of course, checking, of course, that we have a laceration of the cervix when the first baby is born. That is what I have said. Do not allow the woman to bear down or to push if there is still a lip. A lip, it means to say, of course, that the cervix is still thick, meaning to say it is not fully effaced. Pushing or delivering the baby, of course, with, again, not a paper-thin cervix, will going to cause laceration of the cervix. If that cervix is not repaired, the next, of course, succeeding pregnancy could lead into abortion because the cervix is physically injured. Okay? That is why the biggest thing is that first pregnancy, be careful not to lacerate the vagina as well as the cervix because it determines the productivity or the capacity of the woman to be productive and to carry the entire pregnancy, the next pregnancy, as it comes. Okay? That's one thing. Congenital, sometimes women who are exposed, of course, to your diethylstilbestrol in utero. Diethylstilbestrol is a medication, of course, in the 1960s and 70s that's being given to the woman for one belief, okay, that it will help the pregnancy. Meaning to say, of course, that it will secure the pregnancy, it will secure the baby. It does, but eventually diethylstilbestrol use, of course, during the pregnancy causes a lot. One of the most common causes for that one is that it causes sterility to both, of course, babies who are being given, of course, the diethylstilbestrol during the pregnancy. Okay, so if a woman, of course, during the pregnancy, if this woman who is pregnant right now, when her mother is pregnant with her and the mother used the diethylstilbestrol, hopefully I think they could be pregnant. There's a lot, of course, of problems. It could lead, of course, to these things. But commonly, believe it or not, a lot of women who had been used, of course, diethylstilbestrol when she is, of course, pregnant by her mother, cannot even conceive. Okay, that's why diethylstilbestrol right now is banned by the BFAD. That's not longer recommended to be used, of course, in our pregnancy right now. So again, the question will be, could we still save, of course, the pregnancy? Again, if it's a eventual abortion and it is incompetent cervix, that the cervix dilate, what we could do is that cervical circlage procedure or circlage procedure. It could be Sherrod-Carr or McDonald technique, whatever technique. Okay? Sometimes what we do is that we suture, non-absorbable suture, cervical ring is placed in the cervix. So you see the cervix? So once a woman is pregnant, before reaching, of course, the weeks of gestation, once the pregnancy, of course, is presumed, we suture, of course, the cervix. We tie the cervix. Not only tie, we suture the cervix. So the cervix is closed, isn't it? Could it carry the pregnancy? Yes, definitely. It could be a ring. Okay, the most common one is that suture whole cervix closed during the remainder of the pregnancy. Labor, when the woman is having labor now, then of course we cut, of course, the suture is removed or the ring is removed. Sometimes it is permanent. So if it is a permanent, of course, closed sutures to save only the pregnancy, usually what we do is C-section. Okay? So that's one thing. So that's one thing, of course, is that permanent circlage, C-section in order, because again, we cannot open it up because of permanent closure, of course, of the cervix itself. Okay. That's habitual abortion. Another one is inevitable incomplete abortion. Inevitable is that whatever shall we do, even bed rest, medication, we cannot prevent the abortion. Abortion in which the loss of products of conception cannot be prevented. Incomplete abortion is the worst thing. It occurs when the uterus expels some of the products of conception, which is the first one will be, of course, the fetus, and another one, but retain, of course, some portion for the method. Extensive bleeding could occur. So what is the answer if the woman, shall we say, has a spontaneous abortion at home? Okay, how would the woman know that indeed it is incomplete? One sign will be
Bleeding.
What kind of bleeding? How would you qualify? Tell me. When is the bleeding and what type?
Excessive bleeding.
How excessive is excessive? First definition of excessive bleeding.
Spotting? I mean,
No, spotting not.
not in it.
And remember, when the woman is having abortion, the process undergoes the same, just like a complete childbirth. The pain is still the same, just like childbirth. And again, the process of the occurs in the uterus is still the same, just like childbirth. Okay? So now the question will be is that how would you know excessive bleeding? Again, first one is the question is that because you don't know, isn't it? The woman has spontaneous abortion, and again, as aborted, so said, okay, it's done. Okay, those what if it is of course incomplete, it will gonna kill the woman because again, it will destroy of course the woman's system. Plus, of course, it will gonna kill the woman. So the question will be, how would you know objectively that we might have an incomplete abortion? You said excessive bleeding. How excessive? Again, don't tell me excessive because as a nurse, I cannot qualify it. I cannot quantify it. Tell me what is excessive.
Is that more than 400 ml?
Not 400. Don't give me the 400 thing. It should be,
Between 300.
no, that's the normal blood loss during childbirth. And it could be, of course, in the same, of course, with abortion because the process of abortion, in the process of childbirth, the same response that happens to the uterus. Now, quantify because the most common thing, we're still saying, of course, that excessive bleeding. You're right. But again, I want to be specific. I want to be objective.
500.
Correct. 500 at least or to 1,000 in a 24-hour period. I would agree with that one. That's what we call a short incomplete abortion because it's already hemorrhage. It will going to destroy the woman. What else? If abortion and childbirth are almost the same process, what is the most important thing, of course, that you have to monitor? No, don't forget about the umbilical cord because at 20 weeks of gestation, the baby is not a blood clot. Just to let you know, it's a blood clot. Typically, you cannot even see it unless otherwise you're just, if you're eating balut or something like that one, if you are something like one, then probably you could see that one. It's an embryo thing, embryonic origin, okay? But usually you cannot even see it. It's a blood clot, so it's very hard to look for the embryo or the fetus inside during, of course, abortion. So it's not. What else? The most important thing that you know that the woman is bleeding.
Can they massage the fundus and spongy?
It could be the spongy, but again, the burden, of course, of the fundus is very hard at that time because again, early pregnancy, the fundus again in the uterus is not so inflated yet. Because the growth, of course, of below 20 weeks of gestation, you cannot even know, of course, that it's big enough.
Oh,
Uterus contraction?
It could be contracting, and we know that one because again, involution after abortion occurs all these 6 weeks, as a matter of fact. Because again, the process that occurs in the woman's system during abortion and childbirth are all still the same. Think about it.
If the baby's still in her
Evolution.
No, the baby usually is gone. We are talking about abortion. Now the question will be, what are the things you can observe to the woman? I want you to answer me point blank and think about, of course, the process that occurs in the woman. Incomplete abortion, excessive bleeding, defined as 500 or more in a 24-hour period. What else that you were going to suspect, of course, that we have in incomplete abortion? Because incomplete abortion, we lead to bleeding. What else? Blood pressure are signs, of course, of hemorrhage already. Okay, because of course, you have to monitor blood pressure. It could be the objective one, changes, of course, in the blood pressure, decrease in, of course, the pressure, the pulse rate, of course, will be thready and weak. So that it means to say that the patient, of course, is entering, of course, the phase of hypovolemic shock.
Okay.
What else? Think about it.
The placenta is still there.
Yes, that's why again my question is that how would you suspect again? What are the data, objective data that you can see and make you suspect that it is, of course, an incomplete abortion that is happening to a woman?
elevated temperature.
If she has.
There's already complication, of course, of a septic abortion. But again, I'm talking about only incomplete abortion. And again, given, the process that occurs in a woman during abortion and childbirth are still the same.
So the woman go on the shock because of bleeding?
That's already, of course, we talk about that one. Besides that, contractions might be, but it's very hard, of course, to monitor that one. But again, it could be, if you palpated, the uterus, of course, should be, of course, contracted. Okay? And again, because, of course, of the uterus is so big, of course, on the pregnancy, in the full term, usually one thing for that, there is dextral rotation towards the right, means a full bladder. Or another one is that it rises to abdomen and it becomes baggy. That's the risk, of course, of bleeding. Okay? We're done. This is already completely dilated because, of course, the product of conception, of course, came out. It won't come out if there is no cervical dilation. Clear? How about the lochia? How about the lochia? Is a woman, of course, having abortion as lochia? Lochia is a part of a childbirth.
Okay, so it will be the same.
Again, if I will tell you, of course, that abortion and childbirth are still the same process that the one's body goes in through. Now the question is that one is that how about the lochia? If day 3 you still have, of course, a bloody discharge, don't you think, which is the most common one that could be seen, of course, sometimes it is not too massive, okay? The bleeding is not too massive. What if the woman said, of course, that I have abortion, of course, 5 days ago, but I noticed, of course, that there's some fresh blood coming out of me. At 5 days, what is the color of your lochia? Pinkish or? Then why the heck, of course, you have fresh blood, of course, at 5 weeks? What would you expect? That the woman is still bleeding. I would like, of course, for you to answer me with that. That's what answer. That's the answer I'm looking for. Okay? So because, of course, abortion and childbirth are still the same. So look out for the lochia. That's a very important tool. You monitor, of course, the woman after abortion. That's why when the woman is having abortion, the most important thing is that monitor progressive bleeding. What is the changes, of course, of the cervical discharge or the vaginal discharge, especially in terms, of course, of bleeding. It's very, very important. And that's the most common complaint of the woman when she goes to the hospital, ER. They are so weak. It was that, I'm so weak, or blood pressure dropping down. What's the cause of it? Again, the woman might be, of course, saying that it's been, I think I got an abortion 5 days ago, and right now still I have bleeding, fresh bleeding. That's a big, big, big red flag for you to say, oh shit. She needs, of course, the woman needs, of course, to be scraped. And the woman usually, of course, is being prepared for dilation and curettage. We have to scrape everything, the product of conception inside. That's the only way to remove it. Physical removal. D and C, dilation and curettage. Clear?
So, Mr. Lidio, if this didn't happen somewhere there's no medical...
The woman will die. This is the most common cause, of course, of maternal childbirth, postpartum. If this happen, of course, in the middle, of course, of African desert, and usually, of course, even the trained midwives in your thing there, they are not trained, of course, to do that one. Okay? So it's the woman again, probably, of course, because, of course, somebody has declared some voodoo rituals, of course, over the woman, or probably those are, of course, bad evil spirits, of course, that went into the woman died. So again, the babies in these things, of course, is common. But again, if the woman gives birth, there's of course placental fragments left behind. Still the same thing that you're going to see: profuse bleeding or bleeding extended, of course, after 48 hours. Okay. D and C. These are, of course, cervix dilated. So how do we do? Sometimes we dilate the cervix. Okay. Usually either by medication, by drugs, of course, or by mechanical. And again, because sometimes these are physical means and mechanical means, sometimes we cannot avoid, of course, to put injury, of course, to the cervix. That's why, again, DNC, habitual DNC, or frequent dilation and curettage could cause incompetent cervix. That could lead, of course, to weakened cervix that cannot complete, of course, the pregnancy, cannot hold the pregnancy. Uterine wall scrape to remove any products of conception. In this indication will be missed abortion. A missed abortion is fetus has died. So a missed abortion, what is the difference between missed abortion and stillbirth?
But the stillbirth is the fetus is over 20 weeks, and the missed abortion.
Very good. That's how you define it. So if the age of pregnancy, of course, is only below 20 weeks of gestation, in the embryo died inside, missed abortion. Clear. But if the fetus is above 20 or complete the 20 weeks of gestation and died inside, that's our definition of stillbirth. Clear. Okay, good. Fetus has died but remained in the uterus if not expelled spontaneously within 1 month. If again, so usually we're gonna find, of course, any fetal heart rate. We keep it, of course, for 1 month. After 1 month, if it does not go away, then we have, of course, to do dilation and curettage. We have to scrape, of course, the fetus that has died, as well as, of course, the placenta. Okay. Inevitable, incomplete missed abortion occurring between 16 to 20 weeks of the pregnancy, dinoprostone may be administered. Dinoprostone or Prostin E2, again, this is a very important drug in labor and delivery. Okay? Dinoprostone is a prostaglandin that if it will be exposed to the woman, it will gonna cause maturation and thickening and dilation of the cervix. Therefore, if a woman is pregnant and has a healthy pregnancy, we do not want the woman to be exposed to Prostin E. Okay? Clear. What is the result or the action of Prostin E? It will gonna cause the uterus or the cervix to open, and it will gonna cause, of course, the uterus to expel its content. Okay? Therefore, if the woman is healthy and pregnant, do not expose the woman with this kind of medication, especially below 20 weeks of gestation. Because again, why? If the woman receives this medication at 20 weeks of gestation, it will result on only to one thing: complete abortion. So that is why sometimes, if we have inevitable, incomplete, missed abortion occurring between 16 to 20, we could give this medication. Sometimes we give this medication to evacuate, especially missed abortion. We give this, it complete abortion. How would you know this complete abortion? Usually the transition of leukemia is, of course, occurs normally, especially the first 48 hours. Only the one is bloody, of course, or blood will be, of course, the first 48 hours. On the third day, usually it will be pinkish or brownish. That will be complete, of course, evacuation. If not, if prostate E results, of course, to incomplete abortion, then we have to do dilation and cure test. But commonly, the first thing, of course, in order to cause, of course, abortion, will be, of course, prostate E. Now, if you want, of course, to abort your baby between the age 16 to 20 weeks of age of gestation, if you receive, of course, this medication, could it cause abortion to you? Yes. That's why prostate E is a controlled substance. Okay? There's a lot of things. The purpose for the one is that we want to expel the contents. That's the purpose of prostate E. But if we have to save the pregnancy, never, of course, expose it to the woman, because there's a potent prostaglandin. Okay? So another one, therapeutic abortion, legal termination of pregnancy under the physician's direction. So usually, again, even as therapeutic, it is designed, again, the maximum age will be only 20 weeks before 16 to 20 weeks before. Because completion, if it is, of course, 19 weeks and 6 days, it's still abortion. But if completed, of course, the 20 weeks of gestation, so I said before 20 weeks of gestation. Because completion of 20 weeks is already, okay, premature birth. Legal in the United States for medical reasons, for personal reasons. Now, if you are doing non-safe sex, and you get pregnant, and you want, of course, to carry the pregnancy, here in America, you still have an option to abort your pregnancy. Okay? You are not ready. You are only ready for sex. So if you're ready for sex, why did you protect yourself in the first place? How could I protect myself? I'm so tipsy already with that alcohol. Sex and alcohol again. And sometimes, oh, yes, it hurts. Because sex sent me to ER. Did you watch that kind of person show? It's a very crazy show. It's very scripted. They don't like it. Criminal or legal abortion, intervention in pregnancy without medical or legal justification. The one that does that one will be a quack doctor. Okay? Abortion not legal in all situations, carried out in a sterile environment. What are the criteria that is not, of course, criminal or legal? If the abortion is done, one, above 20 weeks of gestation. Clear. Any abortion, of course, that is being done above, of course, 20 weeks of gestation is illegal and criminal. Carried out in unsterile environments will cause, of course, septic shock or septic abortion. Okay? Two things, of course, are major risk for this one. Hemorrhage, because it is not done by a properly trained person. Another one, of course, infection because of the environment. Two major things. Septic shock and hypovolemic shock. It will lead, of course, into two things. Will it kill the mother? Definitely. Okay? Complications of course, of abortion. First one is, of course, two things, isn't it? Whether it is done, of course, legally or not. First two things. Hemorrhage. Then how would you do hemorrhage? You have to monitor the vaginal discharge, of course, after abortion. So again, you have to know by heart what's the progress of the lochia. Okay? If you have questioned that, this is so abnormal. Okay? So then you're going to report it one. It might be, of course, secondary, of course, to a lot of other problems. And again, the most common problem, of course, the most common, not only one reason, the most common reason, of course, why there's bleeding or hemorrhage will be incomplete abortion or incomplete evacuation of the uterus. That's the primary one. There will be a lot of stuff later on. Okay? Post-abortion sepsis, sterility, and ability to conceive. Again, always remember, if you have post-abortion sepsis, the entire uterus will be infected. It can cause scarring in the endometrial lining. The only bad thing about it, one is that frequent dilation in the curettage will lead to inevitable abortion, incompetent cervix. Another one, it could lead, of course, to post-abortion sepsis. If the woman has suffered post-abortion sepsis, chances, of course, that her endometrium can carry pregnancy. Therefore, she will no longer be able to be pregnant if we reach, of course, that level. Okay? Psychological, of course, complication will be depression. Why did I aborted the baby? Blah, blah, blah. You have guilt. Guilt, of course, is the most common one. Anger to who? To yourself, commonly, because of the fact, of course, why did you spread your legs in the first place? Okay? And you don't want to get pregnant. Or whatever happens to that one. Or shall we say is that, oh, it occurs spontaneously. Wow, spontaneous. I cannot prevent it. It happens a lot. It's happened, the thing. So meaning to say, all these things, psychological trauma, of course, that could occur, of course, with the abortion. The worst thing is that you have, of course, several abortions prior, and then later on you were not able to conceive. Okay, that's the worst thing. A woman's blood pressure, you're right. Pressure that spontaneously and rapidly drops may indicate maternal hemorrhage. So again, when do we check vital signs? First 15 minutes times 4, 30 minutes times 2 to times 4, and then 1 hour times 2 or times 4, and then of course progressively to every 2 hours, 4 hours, and 8 hours. Okay, but again, we start always with every 15 minutes. If it's a postpartum woman, you include, of course, in the vital signs checking, of course, one thing is that bleeding, another one, of course, is your fundus of your uterus. Okay, because that's a very important thing. Okay. Another problem in the pregnancy, ectopic pregnancy. What is ectopic pregnancy? You're pregnant, of course, in the throat. Okay, what happened? Why is the pregnancy happening in the throat? Okay? So could it be possible? I don't know, but I haven't heard, of course, a woman get pregnant in her throat. Okay? A woman, of course, is positive, of course, of sperm cell in the throat. I know that one, and it's documented, and we have statistics for that one, but not a woman who is pregnant, of course, in the throat. A woman pregnant, of course, the fertilized egg adhere, of course, to the bowels. Yes, it happens. Okay? Commonly it happens. But again, when we speak of ectopic pregnancy, the location of the implantation does not happen in the uterus. Only one layer of tissues that's capable, of course, of supporting the needs, of course, of this blastocyst when they implant. Usually it is the endometrium. What if the ovum was fertilized? It becomes, of course, a zygote. Okay? Now, it was not able, of course, to access the endometrium, whatever the cause will be. One was that a woman has a lot of sexually transmitted infections. Believe it or not, sexually transmitted infections that ascends to the uterus in the sense, of course, the fallopian tube is the most common culprit of ectopic pregnancy. Why? It causes scarring of the inside lining, of course, of the fallopian tube. So because of that one, the fertilized ovum cannot pass through the scar. So what does, of course, the fertilized ovum will do? It will implant itself in the fallopian tube, which is the most common side, of course, of your ectopic pregnancy, the upper third. Of course, usually, of course, because the upper third is the area wherein, of course, this ovum will be fertilized or meeting the sperm. Okay? Why, of course, I said wherever, of course, the location will be, but the most common will be the tubal pregnancy. The most common problem is that, again, take a look for the one. That portion there is not, of course, equipped with enough thickness, of course, or blood supply that will support the needs, of course, of the developing embryo. So because of that one, the most common problem, of course, of your ectopic pregnancy is, what's the most common complication of your ectopic pregnancy?
That the baby's gonna grow in the fallopian tube and no.
Will the baby survive, of course?
No.
They have to cut
They have
it.
to remove it.
It will not support the baby's needs anyway. But the most common important thing is that bursting. In bursting, the major complication will be bleeding. Okay, again, two major complications, of course, of ectopic pregnancy in two sides. Bleeding and pain. Pain, of course, is presented because, again, even if it is ectopic pregnancy, once it causes, of course, to adhere there and it will be removed, of course, it is painful. Ectopic pregnancy is painful. And again, the major complication will be bleeding. So rare cases, abdominal and ovarian pregnancies. Why abdominal? Remember, the ovary is outside. It's not connected, of course, with the fallopian tube. You see, of course, the fimbriae? You see the fimbriae, the finger-like structure? Supposed to be from the ovary. The ovary is hanging there. Once it split the Graafian follicle, the fimbriae will gonna catch it. What if the left fimbriae, of course, is not trained in baseball? It could happen that the egg will gonna be dropped in the abdominal cavity, in the pelvic cavity, without the fimbriae catching it. Remember, the sperm is having, believe it or not, a sperm, think about the sperm as your drone. The drone or the sperm is programmed to meet and to locate. Okay? The well, that one is that is to locate, of course, the egg cell wherever the egg cell will be. So believe it or not, even it is, of course, again, remember, fallopian tube is open. Could the sperm get out, of course, from inside the vagina, going back, of course, to your uterus, fallopian tube, it could go out the fembrae and jump, of course, the egg, even the egg, of course, is in the abdominal cavity. Could it fertilize it? Yes. So in some cases, we could have abdominal, what it calls your pregnancies or abdominal location, of course, of your ectopic pregnancy. Okay? So where does the sperm comes from? No, not from the behind. Not from the rectum, but it comes, of course, from the vagina. The worst part, of course, is the woman gets pregnant in the throat. So because it didn't occur yet. Okay? So tubal occlusion, that's the most common cause. Intrauterine contraceptive device, IUD. If you have IUD, it disturbs, of course, the environment of the endometrium, preventing, of course, implantation. Okay? IUD or intrauterine device never prevents, of course, fertilization. It only prevents implantation to the uterus. So sometimes, because of its adaptation, the egg, the fertilized egg, might be implanting itself, of course, to the neck, of course, of the uterus, going, of course, to the fallopian tube. Tumors, it could be, if there are some tumors, creating of course, obstruction, pelvic infections that cause scarring, endocrine imbalances, abnormal tubal development, just like, of course, when you are born with it. So usually, the only thing is that pregnancy should occur inside the uterus, or we call it one, implantation should only occur in endometrium. Okay? If outside, we call it one ectopic pregnancy. And ectopic should be terminated. Or if not terminated properly, then it will gonna lead into two things. Bursting of the area it of course implanted, and bursting result only to one important complications, bleeding. Okay? And again, ectopic pregnancies, especially of course if it dislodge, of course, from the area it's implanted, have two things. It could cause bleeding. Another one, of course, it will gonna be causing, of course, severe pain. Symptoms: spotting or bleeding 2 to 3 weeks after a missed menstruation, and there's pain. So again, bleeding and pain are the two distinct, of course, things, of course, in ectopic pregnancy. Require surgical removal of the part or all of the affected tube to prevent rupture. So sometimes, if it is a massive implantation, usually we remove the entire tube itself. Okay? Untreated can be rapidly fatal due to shock from the blood loss after tubal rupture. Okay? So those are the two things. There are things. Fallopian tube, it could cause, of course, in the intestines, in the cervix. This already cervix, of course, is not, of course, the good way, of course, to implant, okay, because it's thin. Okay? If it will develop, if the cervix, this usually, of course, should be removed. Because again, why? The risk, of course, later on is that if this pregnancy will be, of course, not prevented, it could lead, of course, to poor nutrition to the baby. Another one is that if the placenta develops there, the risk, of course, of bleeding is very high because, of course, of the fact, of course, that this lower uterine segment, of course, is not so thick enough. Therefore, contraction of the myometrium or the muscular layer, of course, of the uterus is not so thick enough. Therefore, any placental implantation in the lower segment towards the cervix equals bleeding. Okay? So this abdominal, these are, of course, just the common sites, of course, but the most common site of ectopic pregnancy is the upper third of the fallopian tube. Another problem, gestational trophoblastic disease, hydatidiform mole. This is what I'm saying, of course, as H mole. H mole is a pregnancy, as a matter of fact. The only problem for that one is that, remember, when they develop blastocyst, the blastocyst has 2 layers, isn't it? Blastocyst forms 2 layers. The outer layer will be the chorion. The chorion will be the one to implant, okay? Implant and develop in order to support, of course, the embryo. The amnion part will be the one to encapsulate, of course, a sac. And it will produce amniotic fluid. Inside the amnion, another group of cells will be developed into embryo. That is your baby. Okay? So 2 layers, of course, of the development things. Okay? But the only thing here is that in gestational trophoblastic disease, or H mole, the embryo dies in utero. So do we have an active chorionic villi? Okay? And again, because there's no embryo, it will degenerate. So when it degenerates, it will just grow by itself around, of course, the uterus. The only problem for that one is that what hormone or what part, of course, of the fetus or the pregnancy, of course, produces human chorionic gonadotropin? Which layer, of course, of the blastocyst produce, of course, human chorionic gonadotropin? There are 2 layers of the blastocyst. Remember that? The first layer, of course, will be the inside layer, of course, that will gonna adhere or implant itself to the uterine wall. We call that one your chorion. Chorion. Chorion is the one, of course, that will gonna implant and it will be developing into placenta later on. Okay? The inside will be the amnion. Chorion and amnion are the two layers of the blastocyst. Okay? And the amnion will be the one, of course, to encircle, develop into a balloon that will be, of course, filled with amniotic fluid. And inside the amnion, other cells, of course, will develop there. And you can see, of course, the yolk or the embryo is the growing baby. That is why when the baby grows older, it is swimming, of course, in the amniotic fluid. Because the amnion has only one purpose, to protect the developing embryo. What's the purpose of the chorion? To make sure that there's resources for the developing embryo. That's why it has to implant itself. Correct. Therefore, the chorion will be the one, of course, to be developing into your placenta. Okay, now the question is that on the first weeks of pregnancy, just what shall we say, on the while the embryo is developing in the first 8 weeks, okay? What is the first hormone that we check in order to make sure, of course,
HCG.
human chorionic gonadotropin, and what part of it, what part, of course, of the blastocyst, of course, that is coming from? Chorion, the one that's developed in the placenta. Because once the chorionic gonadotropin, once the placenta will be maturing, it will decrease, of course, producing human chorionic gonadotropin. It will be replaced by human placental lactogen. This is, of course, placental lactogen to make sure that, of course, the baby is growing properly. But the purpose of the chorion, always remember, human chorionic gonadotropin is to change the environment inside the woman's system in order it will support the pregnancy. That's the mandate of the chorion. Implant, sap, of course, every natural resources, or root, make sure that you develop roots, and later on, of course, to make sure, of course, that the mother system, you tweak, of course, this entire mother system in order to support, of course, the life of the embryo. And later on, once this is established, once it is, of course, past the embryonic life, usually in the second trimester, then, of course, human chorionic gonadotropin will going to drop and will replace your human placental lactogen. Because the human placental lactogen will be increasing and maximizing all the resources of the mother in order to support the growing baby. Just like increasing blood supply in the GI tract to absorb more nutrients, increasing, of course, primarily the blood volume, of course, of the mother in order, of course, to support, of course, the needs of the growing baby. That's the hormonal effect, of course, of pregnancy. Now, my question here, of course, is that in hydatidiform mole, the embryo dies, there is no baby. But there is still the chorion. And the chorion degenerate. So again, during the first weeks of pregnancy, the embryo dies, and embryonic life is only, what's the age of embryo?
8 weeks.
8 weeks. After 8 weeks, it should be a fetal life, isn't it? Therefore, if embryo dies during the first 8 weeks, we still have an embryo, but within that time period, the embryo dies. We still have an active, of course, chorionic villi, because it's attaching itself. It degenerates, but it creates, of course, it populates itself because it sucks nutrition, but it doesn't have embryo to feed on. What does it do? It will gonna grow itself. So if you check this woman, is this woman you positive with HCG? Is this woman who is, of course, having gestational triple disease or have HMOL, is the woman positive with pregnancy test?
Yes.
Why? What are we testing?
Yes.
HCG. So that's the thing that we are checking, whether in the urine or in the blood, this woman is positive with pregnancy test. The only problem is that, yes, the chorionic villi will gonna be, of course, because again, it's sucking, of course, some nutrients from the woman's endometrium, it will gonna, of course, support itself and build itself. You can see the woman's, of course, abdomen growing and growing and growing and growing. As a matter of fact, an H-mole pregnancy, of course, or a molar pregnancy, push the abdomen faster than the normal pregnancy. Okay? So that's why, what is it you can see? Passive HCG, woman's abdomen is getting bigger, feeling pregnant. Yes, nausea and vomiting. That's cause of hormonal changes. There is, of course, morning sickness with this condition. As a matter of fact, these things, of course, were going to cause severe nausea and vomiting. As a matter of fact, this is one of the culprits of hyperemesis gravidae. Okay? So that is why what happens is that uterus then enlarge more rapidly than usual. At first, pregnancy appears normal because, again, there's growing passive HCG in the line. The only problem later on is that we cannot get, of course, a fetal heart rate because there's no embryo that's developing. There's no fetus. Now, episodes of spotting and bleeding with brownish red discharge, tapioca-like. So see tapioca, small circle, of course, things, tapioca vesicles. it is producing out there. It's being, of course, expressed there. And you can see, of course, that it's spotting. And that will be the time, of course, that we're going to see, of course, that we have to do ultrasound if indeed we have some fetus inside. If there's no fetus inside, what shall we do? We have to terminate the pregnancy. How do we terminate the pregnancy? We have to remove the chorionic villi. How do we remove it? Very good. So therefore, molar pregnancy, the end product for the one, of course, is DNC. We dilate it, we scrape it, everything. And we allow the endometrium to heal. Okay? Okay. So HMO, vaginal bleeding, spotting, and release, of course, of tapioca-like vesicles. Okay? Uterus that is larger than expected for weeks of pregnancy. Now, believe it or not, it absorbs a lot, of course, of blood resources, of course, from the mother. Because again, why? Believe it or not, the chorionic villi, of course, doesn't have, of course, liver, spleen, of course, to produce blood. Therefore, it sucks the woman's resources. That's why the woman is very anemic. Anemia is expected for a woman who has HMO pregnancy. Okay? Because again, there is no fetus to produce more RBC. Excessive nausea and vomiting, as I have said. Because, of course, of high level, of course, of your HCG. Because nausea and vomiting is only caused by rapid increase, of course, of your hormonal imbalance. Signs of pregnancy-induced hypertension, another one, PIH, or pregnancy-induced hypertension, blood pressure of the woman is skyrocketing high, okay? Before 24 weeks of pregnancy. So again, at 24 weeks of pregnancy, if you don't remove it, it will gonna cause the woman to have PIH, or pregnancy-induced hypertension, one of the major complications of pregnancy that will kill the woman if not managed properly, okay? So what is the difference? How would we know that it is, of course, HMO? Now, fetoscope, no fetal heart rate, no fetal movement, no detection of probable fetal parts. So, but usually what we do is that, no fetal heart rate, and not only fetoscope, we have to do ultrasound to make sure that there is no fetal tissues that's developing, okay? And that will be the one we have to DNC, okay? As much as possible, we want to do the DNC before 20 weeks of gestation or around the 20 weeks of gestation. We don't want to wait, of course, for the 24 of course, weeks. Because again, why? PIH will be developing. So that's why we have to terminate that kind of pregnancy. We call it one pregnancy. We call it one molar pregnancy. That's not a true pregnancy. Okay? So sometimes, again, follow-up delivery. Human chorionic gonadotropin titer must be done. So we remove, of course, we scrape it. So now, we want to make sure that we remove all the chorion. How do we do that one? We have to check the human chorionic gonadotropin. Clear? In the blood. So again, titer that remains high rises indicative of a cancer. A cancer that evolving the chorion. We call this one as your choriocarcinoma. A choriocarcinoma is a cancer cell that develops inside the endometrium, which of course usually the genetic makeup, of course, for that one is partly part of the mother and part, of course, of the baby. And that is a cancer form. Okay? So sometimes choriocarcinoma is a malignant form of endometrial cancer. Okay? Treated with chemotherapy. Sometimes, if you cannot avoid pregnancy, again, now, if we have choriocarcinoma, the biggest thing is that if the woman is a big HMO. So again, we do, of course, a DNC. After we do DNC, we have to monitor, this is the things, okay? The woman is positive with HMO pregnancy. So went to the doctor before 24 weeks of gestation because we don't want the woman to have PIH or eclampsia, okay? Now, we scrape it, DNC. Now, after DNC, the woman shall be monitored, of course, for the presence, of course, for HCG. What is the level of HCG? It is very important to monitor because why? If the HCG is still high after weeks of DNC, it means that we have cancer. Clear? If it drops down, we still have to monitor, of course, the woman until such time and recommend the woman not to be pregnant for the first year. The purpose, of course, of the HMO is that we want, of course, the woman to prevent pregnancy on the first year after the DNC. So we want the woman, of course, to monitor, of course, that the human chorionic gonadotropin drop down in negative for the period of 1 year before the woman could get another pregnancy. Clear? That's the goal. So if the woman, of course, has choriocarcinoma, then we have to treat it with chemotherapy, progression, and of course, a woman who has choriocarcinoma could barely get pregnant. If the woman gets pregnant, it will gonna cause, of course, inflated growth of your choriocarcinoma. So that's why we don't want the woman, of course, to get pregnant during the time. Even with HMO, always remember, One of the criteria, when is the woman ready, of course, to have another pregnancy after HMO? The answer will be 1 year of negative HCG in the blood. Clear. Then the woman is ready for pregnancy. Just like when the woman, of course, is having rubella infection, or shall we say, has been vaccinated with rubella, when is the woman ready, of course, for pregnancy?
After 3 months.
Correct. At least 3 to 6 months after the vaccination. Because we don't want exposure of the fetus, of course, during the pregnancy. Okay. Any contraceptive methods other than intrauterine device, because we don't want any intrauterine device, because again, it disturbs, of course, mechanically disturbs the inside, of course, of the uterus. Rh negative woman, again, anybody who has bleeding, spotting, Rh negative woman, we have to give the anti-D or the RhoGAM vaccination. So again, in normal pregnancy, for a woman, of course, who is Rh negative, RhoGAM should be given at 28 weeks. When do we give RhoGAM? The answer will be in a low-risk pregnancy of an Rh negative woman, it should be given, the first dose will be given 28 weeks. Or if there's any episode of bleeding, vaginal spotting, molar pregnancy, it should be given at the time of possible exposure to prevent sensitization of the woman's system. Okay? So that's one thing. So prevent Rh sensitization. What is Rh sensitization? An Rh, it only occurs in an Rh negative woman who develop antibody against Rh factor. Therefore, any Rh factor tissues that could be exposed inside the system of the woman, both blood and both the fetus, who is Rh positive, the RBC will be destroyed by the mother's antibody against Rh. Clear? Therefore, our goal here for Rh negative woman later on is that to prevent sensitization. So that again, if the woman will be pregnant with a future child that is Rh positive, the woman's system will not kill the fetus inside. Okay? How about if the woman has antibody already? What can we do? The woman, first pregnancy, Rh positive. During childbirth, the woman didn't know about it. It's of course a cultural midwife who delivered the baby without knowing that the baby is Rh positive and the woman is Rh negative. Okay? So first pregnancy, the baby, this resulted in normal pregnancy because again, the exposure of the blood is only during childbirth. Succeeding pregnancy, we didn't know that the woman, of course, is the Rh negative. It happens that the woman's system developed antibody, of course, against, of course, Rh. Second pregnancy, the baby is also Rh positive. And again, the woman's system, we're going to try to destroy the RBC of the Rh positive baby. What can we do about that one?
Give it that time. After globin.
Could we still give, of course, RhoGAM to an Rh sensitized woman?
Yes, because it's a higher risk.
Again, the woman is already sensitized, meaning to say she developed already antibody, whatever the cause will be, commonly first pregnancy. Okay? Now my question will be, if the woman is Rh sensitized, okay, and the woman gets pregnant again for a next second time probably, and this time as well, the baby is Rh positive, could we give RhoGAM to the woman?
Yeah, 28 weeks.
Could
No,
we?
Because RhoGAM is given just to sensitize the patient.
No.
No, 28 weeks.
I know, but again, my question is, you don't listen, of course, to the scenario I'm giving, which will gonna make you, of course, always fall for the obvious wrong answer. Okay? Think, critical thinking. That's what, of course, I want, of course, to spit out to you, and I want you to possess that one. It is simple logic. Does it make sense? Does it not violate, of course, the principles? Always think about the principles that we are talking here. What I'm talking to you, of course, are the baseline, of course, the way, of course, of thinking. Analysis is a higher form that I'm asking from you, but you have to utilize all those. Again, now, RhoGAM is given, of course, usually to the woman who is Rh negative. Rh positive woman, forget about it. They don't have any problem. Rh negative woman, especially if they're exposed to possible Rh positive, of course, factors. Because again, exposure to Rh factor will gonna trigger them to develop antibodies. The most common factors that will be presented to them will be, of course, pregnancy of an Rh positive baby. Okay? Either it happens usually commonly, it happens during childbirth because it's the only time that the baby's blood could be exposed to the maternal blood during placental separation. Okay? Now the question will be is that to prevent sensitization, usually we give RhoGAM at 28 weeks, or in any event, abortion, spotting or bleeding, even amniocentesis, we have to give RhoGAM because again, there's a possible exposure. Okay? Because of course we puncture, of course, at one, even by how minute we still give, of course, raw gum. And again, later on, within 72 hours after, of course, delivery, because we know that raw gum is effective in preventing development of antibodies, or the term sensitization, for 12 weeks. So 28 plus 12 equals 40. 40 is the normal age wherein the baby will be born. Now my question will be, first pregnancy, the woman didn't know that she's Rh negative. And she didn't know, of course, that the baby is Rh positive. Upon birth, upon childbirth, the woman is exposed. Therefore, the woman developed antibodies against Rh factor. Therefore, the woman is sensitized, quote unquote. Okay? Now, the woman, here comes again the woman, pregnant the second time around. And the baby at that time, if the baby is Rh positive, could we give raw gum to this baby? Probably, this first baby was born in India. Okay? And the second pregnancy, of course, was born here. What happened here in the United States, shall we say? I'm not saying, of course, there is no raw gum control, of course, in India there is. But shall we say, in a very remote culture or province, of course, where there is no medical interventions. Or probably it happened in Asia, in Africa, whatsoever. Here comes, of course, the woman is sensitized. Do we still give raw gum at 1 to 8 weeks?
1 to 8 weeks.
Again,
20.
my second pregnancy, there's no spotting, there's no bleeding. The only chance we could give, of course, probably is that 1 to 8 weeks. Again, the woman is sensitized because of the first pregnancy. Okay? Do we give raw gum at 1 to 8 weeks? Do we give raw gum on the second pregnancy, 1 to 8 weeks of gestation?
Yes.
The answer is no. Raw gum is useless once the woman develops antibodies. The only goal of raw gum is to prevent antibody production. Clear? Therefore, if the woman is sensitized and she has antibody, there is no action for the raw gum. Whether you give them IV raw gum, it's useless. Because again, the purpose of raw gum is only to prevent antibody formation. Once antibody is developed in the mothers who is Rh negative, there's no way. Again, you're just hoping, of course, that the baby is Rh negative. Because the baby has no Rh factor, therefore the baby could be carried out throughout pregnancy. If the baby is Rh positive, that is a very, very high risk pregnancy. Hoping that the baby is still alive after 20 weeks of gestation. Meaning to say before fetal viability. That will be the time that probably at 22 weeks, we have, of course, to do a PUBS, percutaneous umbilical cord blood sampling, and insert a catheter, and have to do, of course, a intrauterine blood transfusion to the baby to save the baby. Okay? So again, clear. One thing is clear. Once the woman has antibody, we call the woman Rh sensitized. Meaning to say the woman is sensitized, quote unquote. Since Rh sensitized woman means, of course, that they are Rh negative but develop antibody. How they develop antibody? They have to be presented with a factor, with the Rh factor. It could be blood transfusion with an Rh positive blood, or it could be, of course, a baby is pregnant with, of course, Rh positive blood type. Okay? Once the woman is sensitized and has antibody, there's no way we could do about the woman's system. Nothing. Treatment, nothing. Even electrophoresis, we cannot do. So the only thing is that praying that the damage, of course, that will be created with the succeeding pregnancies of Rh positive fetuses, of course, will be later enough, and again, the fetus will be still alive before reaching 20 weeks of gestation. If not, we still can push, of course, a fetal maturity. We can do, of course, intrauterine blood transfusion, or else we have to deliver the baby to put the baby a chance to survive. Clear? That's how tough Rh incompatibility is. Okay? Yes, your question, Mr. Jones.
Yeah, my question is, so the pregnant woman can be Rh negative, and then the fetus also can be Rh negative.
Sure.
In that case, they don't give nothing, because
No,
there's nothing.
There's no problem.
What are the percentage of both the mom and the mother being negative and then?
I don't know.
Okay.
I don't have the data for that one, to be specific. Because again, whether it was the baby, again, usually whether the baby is Rh negative or positive, no. The only important thing that we have to know is the woman Rh negative or not. That's why at 28 weeks of gestation, I want blood type to every woman. Okay? Because I want to know if they're Rh negative or Rh positive. Okay? If they are Rh negative, we don't even check the
Right,
baby.
they check the fetus.
We don't
Okay.
even check the
Okay.
fetus.
All right.
Right away, raw gum, whether the baby is Rh negative or not.
20 weeks.
The what?
20 weeks.
Yeah, usually 20 to 20. Usually that's the time. You ultrasound, sometimes we do blood test. The purpose for the one is blood typing. So what's the blood type of the woman? Plus, of course, blood type, of course, will be positive or negative. It's like O positive. The positive and negative part is the Rh type. Yeah? So if the woman is O negative, or perhaps shall we say is AB negative, that will of course trigger us. Do we check the baby if the baby is RH positive or not? Not anymore. Right away, Rogam, because we don't want to stand the chance. Clear?
So if the woman is RH negative,
That is the only woman, of course, we can give Rogam.
and that will give Rogan, you don't even check the baby,
We
right?
don't even check.
Even if the baby, so it won't hurt the baby, if the baby is RH now negative too, right? It won't
So
make
be it. So this is safe, of course, for the woman.
All right.
So what does the blood transfusion do to the baby? I mean,
Okay. So now you realize, of course, what is the gravity, of course, of the damage.
Next time.
That's the next step, okay? No, that's the thing. What the blood transfusion? Why do we give blood transfusion? Why we give blood transfusion? What is the problem in the first place? Why we have to give transfusion to the fetus or the baby? That's not the answer. That's the pathology of what is RH incompatibility. Now the question will be, what is the indication of blood transfusion, especially packed RBC? What is the indication? Why we give blood, packed RBC or RBC to the patient?
Have enough RBC.
Correct. They don't have enough RBC. What is the function of your RBC? It contains the hemoglobin. What is the function of your hemoglobin?
Oxygen.
It carries oxygen to distribute to outer system, to the brain, to the body. If you don't have RBC, you will die. All your cells will die because there is nothing that will carry oxygen. In a fetus that is RH positive, in the mom, of course, is RH sensitized, meaning antibodies. Antibodies could cross the placental barrier. Therefore, it will gonna go inside, of course, the fetal circulation or the fetal system. Now, the antibody, what it does, it hunt and destroy all the RBC, of course, of the baby. Therefore, the RBC of the baby, it will come to the point, of course, that most of the RBC of the baby is dead because, of course, the maternal antibodies will destroy the RBC. Now, we cannot wait for the baby to produce more RBC, or else it will gonna die inside the utero. If before 20 weeks of gestation, it is already a missed abortion. Or if not, if it is greater than 20 weeks of abortion, it will be stillbirth. The only way to save that one is that to give them rapidly more RBC. The only way to do that one is that we have to insert that catheter and give, of course, packed RBC to the baby directly.
okay, then how long does it last? I mean, you have to deliver the baby after certain time when you.
Then again, my question will be again is that when do we safely deliver the baby? If condition persists as much as possible, we want it, to, of course, to be greater, of course, than 20 weeks
So
of
once you
gestation.
give the transfusion, that transfusion could be permanent. I mean,
What do you mean permanent?
I mean, the
We don't remove the
I mean,
tube.
the RBC doesn't deplete anymore. I mean, it just.
RBC live again. You have, of course, to go back, and that's the thing. That's a wondering thing, isn't it? You have to understand also what is RBC. RBC could only be surviving in your life, in my blood, in baby's blood for only 90 to 120 days. If after that period, and the baby is not still delivered, another transfusion should occur because all the RBC, of course, has dead already. Okay? It is not permanent. You are probably thinking, of course, of a transplant thing. It is not a transplant. Blood transfusion is not a transplant. After 90 to 120 days, the blood that you give are dead. So if the body is not producing more RBC, then you have to replace it. These are the people, of course, who have, I call them, of course, Dracula. Like later on, especially, of course, they need, of course, blood transfusion to survive. Every 90 to 120 days, every 3 months, they have to sit down to receive blood transfusion because their body is not producing RBC. Okay? So that's it. It's not permanent because, again, it will be destroyed because their life is only for 90 to 120 days. Did they answer the question?
Yeah.
Okay, good. So again, bleeding in pregnancy or labor is a sign and must be reported again to the provider to be given, of course, your ROGAM. Now, is the ROGAM clear? Okay. So what time is it?
6:13.
6:13. Okay. Is that okay if you will gonna go on break only for around 20 minutes? Don't stay because we have a lot, of course, of things to discuss. Okay? And think about if somebody, of course, my joke always remember in the community that if somebody has morning sickness and shall we say it might be acid, it might be, of course, pregnancy. Any woman, for me, I always joke them. Is that something else? Turn around. The next thing you know what I'm looking, could you turn around? I want to see the hips. The first thing you will see is broadening of the hips. Why there's broadening of the hips? In order to support the pregnancy. Nausea and vomiting and broadening of the hips, it's not, of course, worms inside. It's a different worm that came inside. Okay? That produces, of course, pregnancy. It's always pregnancy.
And
Okay?
the pulse
Mm-hmm. In the pulse. Or probably, not the pulse, but you can see, of course, the jugular, of course, artery. You can see that it's palpating. You can see that one, isn't it? Because why it happens? Because the blood volume of the mother is expanding. It's increasing. Okay? Okay. Now, morning sickness ends at 12 weeks. Any morning sickness, of course, that extends beyond 12 weeks to 14 weeks is classified as your hyperemesis gravidarum, or any no morning sickness that causes, of course, lose weight of the woman is equals hyperemesis gravidarum. And again, hyperemesis gravidarum could be utilized, could be managed, of course, by medications that will suppress, of course, nausea and vomiting. But if not, it could cause, of course, shock to the mother, and usually, of course, that's in the worst case, we have to abort, of course, the baby in order to save the mother. Okay? Pernicious vomiting. The reason for this one, the cause of morning of hyperemesis gravidarum is unknown. But the most common and possible culprit for this one is the hormonal imbalance. And we try, of course, to push, of course, the cause, of course, for the HCG, a rapid rise of the human chorionic gonadotropin that usually stimulate, of course, nausea and vomiting. Although to be specific, it's not it, but again, that's the most common, visible, of course, cause. Okay, signs will be persistent vomiting to the point of excessive weight gain, dehydration, severe loss of appetite, acetone in the urine. If there's acetone in the urine, there's a big, big problem because, again, we might be talking, of course, that we have, of course, renal failure. Okay? So signs will be excessive salivation. You have, of course, thialism. We know that thialism doesn't cause dental caries. Epigastric and rib discomfort, secondary to retraction, of course, of your diaphragm when you cough and vomit. Okay? Constipation of diarrhea, anemia. Although anemia goes hand in hand with pregnancy, that is why the first purpose besides folic acid supplementation to the woman is pregnant is iron. Why iron? Because when a woman pregnant, there is a sudden rise of blood volume. If there's an increase in blood volume in order to support the circulation of both the baby and the mother, the most common problem is the hematocrit decreases. Hematocrit is the composition of RBC in a given specific amount of blood. Therefore, all women who became pregnant is expected to be anemic. That is why iron, we give iron and folic acid and B12 for this woman if needed, commonly iron, in order to support, of course, the production of more RBC and hemoglobin. Okay? Electrolyte imbalance, few drugs usable without potential harm to the fetus. That's why, if after, of course, antiemetics, okay, is given to the woman, it is not, of course, still manageable, then the next level, of course, could be managed. Remove, of course, the pregnancy. Okay? IV glucose, antiemetics, sedatives, we have, of course, to sedate. Severe headache, mental aberrations, delirium. Advanced stages, it only shows, of course, one thing. If there's severe headache, mental aberrations, and delirium, it only shows that we have a severe electrolyte imbalance. Vomiting, the most common thing, of course, that will alter will be your potassium. Do you know what is the role of potassium?
Yes.
What is the role of potassium in the function, of course, of the human body?
Support the red blood cells.
Not necessarily.
Pumping of the heart.
Potassium, very good. Very good correlation. It affects the pumping of the heart. Okay? Low potassium, because I'm a dialysis nurse, so potassium is my life. Okay? Low potassium, it will include, of course, bradycardia or arrhythmia. So two things, either low potassium or high potassium, it will result into your cardiac arrest. Pick it or not. Okay, so that's why it's very important. We're going to talk as we go along with the med search for that. Okay, so hyperemesis gravidarum, coma, jaundice, especially if, of course, there is, of course, a increase in bilirubin, cyanosis, abortion to save the woman's life in severe cases. Okay, pregnancy-induced hypertension. So problems. Who are the people, of course, who are the women who have high risk to develop pregnancy-induced hypertension? Obese? Not necessarily. Diabetics could be. Who else? In terms of age?
Over 35.
Over
No, 40. Okay, your books is 40, so I'm gonna honor the 41, okay? 40 and below? 16. Adolescent pregnancies, 90%, especially below 16, result to pregnancy-induced hypertension. Okay? In first pregnancy, above 40 is usually, of course, result to pregnancy-induced hypertension. Okay? What is the problem with pregnancy hypertension? Again, what the heck? If the woman is hypertensive during pregnancy, what is its effect to the woman and the baby in a way? First one, if the woman becomes hypertensive, what is the result for it to her system when she's pregnant? Think. What happens to the woman if she's hypertensive? What are the risks? Come again? It could be.
Bleeding.
Abortion, bleeding could be. Why? Why bleeding?
I don't know. Blood volume? No.
Because in the first place, anybody who has high blood pressure could lead, of course, into two things. What is that? Stroke. Yes, bleeding, because again, we are talking about hemorrhagic stroke. That's why I'm asking how. Because there's two things. Hemorrhagic stroke will be the most common one. That's why anybody, even not pregnant, if they are hypertensive, the risk is always stroke. Besides stroke, the next thing that will going to happen, of course, will be myocardial infarction, okay, or heart attack. These are the two most common problems, of course, of hypertension. Think about it. If this woman is, of course, hypertensive, she is prone to stroke and myocardial infarction or cardiac arrest. What is, of course, the effect of hypertension in the woman to the growing fetus?
There's no blood oxygenation.
Very good. Low oxygenation or low perfusion to the fetus. And the result will be dramatic. One, if the baby could survive, it could be, of course, small for gestational age or intrauterine growth retardation. Or if not, again, it could lead, of course, to a lot, of course, of serious other things, up to the point of termination of pregnancy, abortion. It could lead to abortion, of course, of the pregnancy itself, if the woman is present into hypertension. Okay? So that's that thing, okay? And the woman here is that the pregnancy-induced hypertension is not only that one that its stroke is occurring, the most common risk for this woman is to develop seizures. Okay? Hypertension and seizures are the two most common problems, of course, in the one we have PIH. But first one, we have hypertension. Another one, we have edema. Edema, of course, what is edema? Accumulation of swelling, not only swelling. I don't want, of course, to define that one. So there's swelling, but again, with swelling, of course, I will gonna blame it to itis. But again, it accumulation, of course, of fluids in the interstitial compartment. It could be happening in the legs, increase in the size, okay? Extremities, it could happen, of course, all over the body. We call it one anasarca. Or it could happen, of course, in the abdomen, in the peritoneum. We call it one as your, what do you call, of course, the edema of the abdomen? Ascites. Okay, that's the term. So edema, proteinuria. Proteinuria is that loss of protein. Why we have edema? Because number one, of course, is that why we have edema is that we are losing protein in the urine. Okay? The normal protein, of course, in the system that, again, in terms hemodynamically, of course, speaking, why does the fluids is being maintained in, of course, only, most commonly, of course, inside the vascular compartment. When speaking of vascular compartment, it is inside, of course, the blood vessel wall. Why? Because in the blood, there is protein produced by the liver that, again, creates just like a magnet. A magnet to pull water from different areas to go into the vascular compartment. That protein is known as your albumin. Okay? Therefore, albumin exerts, of course, a magnetic effect to the water around, of course, the tissues to go back intravascularly. Because, again, only the water intravascularly could be managed by the system. It could be excreted through the kidney. It could be reabsorbed anywhere else. Or it could be, of course, maintaining the blood pressure. So anything, of course, if you have a low protein in your bloodstream, the tendency is that there is no magnet, there is no force, okay, that will attract water to go back to the vascular compartment. Therefore, the water seeps through, of course, the blood vessel wall, causing, of course, your edema. Edema is just secondary, of course, to your proteinuria. And that principle, of course, of this albumin exerting a magnetic effect to the water is what we call a short osmosis. Therefore, albumin, the function of albumin is maintaining osmotic pressure in the intravascular compartment. That is a med-surg concept. But again, it occurs also, it happens in this woman, okay? And this hypertension could occur, of course, antepartally before the baby is parting or giving birth, during the birth, or postpartum. So it depends on that one, but again, I said that rapid rise. We have some terms, of course, in pregnancy induced hypertension. We call that one as preeclampsia and your eclampsia, okay? So major contributor to maternal and fetal morbidity and mortality. If this is not managed properly, it will kill both. This is one of the most common cause of killing, of course, the mother and the baby. Treatment will be controlling the symptoms. And the primary symptoms will be hypertension. So that. And the second thing will be, of course, is that allowing labor to start normally or initiating it when the safety of the woman and fetus as best permits. As much as possible, we keep the baby until maturity, close to maturity. Following delivery, continue to monitor. So this pregnancy-induced hypertension could be very, very common among other people, of course, who are DM, or another one is that for women who have already been hypertensive before pregnancy. Again, if the woman, of course, will be given, of course, is one to imbalance, of course, hypertension, but sometimes in women with PIH, hypertension only occurs during, of course, the pregnancy. Okay? 6-week checkup. So again, that's why after delivery, if the woman delivers, this 6 weeks is very important for me. Why? If we have complications just like of course, birthing or what this one, 6-week checkup is very important. So in 6-week checkup, we check, of course, the blood pressure. If the blood pressure still is elevated during the time period, the woman is defined as not only having pregnancy-induced hypertension, but a hypertensive disorder. So the woman is having high blood pressure as her own diagnosis, not related to pregnancy. Okay? At the same time, we have to check, of course, complete involution, of course, of the uterus, properly placed uterus, so that the uterus, of course, will be coming back, of course, this normal size, normal layer, of course, of the endometrium, so that it is ready now, of course, for another sperm from the father for possible next pregnancy. Okay? So, but even though sometimes the total system of the mother is not ready, of course, for 6 weeks to get pregnant right away. That's why, after a 6-week checkup, if the woman again has menstruation or not menstruation, contraception is being indicated by the OB in order to prevent right away pregnancy. Okay? So complete blood count, because we want to know, of course, especially albumin level. Blood urea nitrogen. BUN is a very important tool, of course, if indeed the kidney is functioning properly. Because by the mere fact, would you know, of course, that albumin or proteins are big molecules? Normally, they are not allowed to go through the other side, of course, of the kidney. So once, of course, we remove the dirt, the protein, the albumin, always stays, of course, on the healthy side or on the circulation side. It doesn't go, of course, to the filtrate, we call that one, okay, because they are so big. Thus, the size, of course, of the filter is so small enough to allow this protein. Therefore, if the woman is, again, releasing protein in the urine, it means to say, of course, that the filter is also damaged. It widened. Okay, so that's why BUN, urinalysis, creatinine, these are very important to make sure indeed that we don't have any renal failure. Okay?
That means, sir, if you have kidney disease, you have edema. Is that right?
No. First one is that it's not direct, but again, it could be. But again, I would like, it could be, but it's a direct, already, it's a rapid jump. So again, if you have kidney failure, first one, the filter is damaged. It allow albumin it allow albumin, of course, to be wasted. That's the first thing. Okay. Then, because albumin, so again, fluids will gonna seep through. Okay, that's the first pathology. If the patient is end-stage renal failure, just like my patients, they don't produce urine because the kidney is dead, no functional kidney. So what happens? The fluid stays in the system. So if there's too much pressure in the vascular compartment, where does the fluid go? Interstitially. That's why people who have end-stage renal failure, who didn't go on dialysis, of course, for the 2 days, which is the most common patients I've got in the middle of the night, usually I have to go there, the patient cannot breathe. And then we're going to take down 4 to 6 liters from the patient. After that one, the patient, I want to go home. I feel good. Because they missed dialysis. So we need to say if they're not producing urine, where does the water go? Outside the vascular compartment. The blood pressure, more than 200, 210, 220. The fluids that only, of course, on their legs that is protruding, believe it or not, almost 1/3 of their lungs are full of fluids. You can hear these people, of course, breathing water. So we call that one audible crackles. Okay? With only one thing, pulmonary edema. The edema is not only in the legs, it's already in the lungs. It only shows, of course, which is true, of course, for those people, not only with kidney failure, but also for the people who have congestive heart failure. Okay? Okay. So, but again, that's not indirect because I would like, of course, to analyze first, of course, in between. which is probably, if they have end-stage renal failure, is edema expected? Edema is part of your assessment. What is the level of edema they got? Because again, the level of edema signifies, of course, how much fluid you're going to take from them. And edema presentation, of course, will be, like for example, with me, doc, like for example, to just share with you in the medical perspective, I have a patient stat, so gasping for breathing. The blood pressure is only 95/46. So again, I got to remove, of course, 4 liters, or else the patient will going to go sudden drop in blood pressure. So hypotension will going to lead, of course, into unresponsiveness. So I will tell the doctor, doc, we have audible crackles, and we have plus for edema bilateral, of course, pedal in the entire legs. Could they have an albumin? So are you going to use albumin? I'm going to be transfusing albumin because, again, the purpose of albumin is that it creates a magnet intravascularly to suck the water from the interstitial part, put it, of course, in the intravascular, and then if they are already inside the bloodstream, I can pull it out. Okay? So I can do that one. I can do, of course, 3 back-to-back albumin, and again, my blood volume is increasing because I have fluids coming inside, of course, the system. So that my blood pressure is maintained, and the patient, and they can remove, of course, the fluids. That's another trick, of course, when you are doing, of course, when you are talking hemodynamics. Okay? So I do that one always. It's part of my world every day. So my world will be always to handle blood every day. And sometimes I have there's another patient, I cannot believe it. Okay, when I started this one last 3 weeks ago, the woman is pregnant. I have, of course, to do dialysis. And the woman, of course, has, again, problems with manic depressive disorders. And the woman, of course, went into coma. Okay? Went to coma and have, of course, to do dialysis. I'm waiting, of course, that come on, OB, come up. I want to hear the fetal heart tone. And eventually, in the middle of my dialysis, here comes, of course, the OB. And then they check, of course, the baby, and they can hear, of course, the fetal heart tone. And have to be thankful that even the woman is in coma, the baby is still awake.
She wake up?
The woman, she's in a coma, so she's still in coma. So she's start to move because sometimes if we have to intubate an individual, we have to force them to push them into coma, or else they're gonna pull out, of course, all the tube. She get respiratory distress. She got, of course, been severely dehydrated. She is pregnant, and the BUN is very, very good. And on the sides for that one is that I think she's a drug user. So these are, of course, the complications, of course, of the people I see every day. So I have to talk with the dialysis. It's usually the setting for that one is ICU. So usually I'm the one who was doing, of course, bedside dialysis, hemodialysis, of course, in the ICU. Okay? So blood pressure is my thing. Clinical, of course, management is my thing. This is my own history, of course, my part of me, because I was exposed, of course, to this concept. Okay?
Is the baby cell can survive even if the mother is in coma and having dialysis?
That's why we have to monitor. So we have to get the stethoscope. And and I'm so happy to hear, of course, the fetal heart rate that is within normal range. I think that the heart rate is 137. So 137 is in the parameters. So I thought we have to help, of course, the woman gain, of course, until, of course, we have a lot of medications given to the woman to stabilize, of course, the woman. So again, I think, of course, we will going to transfer that woman to another more advanced level of hospital in order, of course, to take care, of course, of the baby, of course. The woman is, of course, I think the woman is 26 weeks pregnancy, AOG.
So they can take the baby out?
No, come on, I don't want to take out 28 weeks. You're going to see, of course, how poor was the baby below 35. So my rule will be, please, closer to 35, please. So sometimes doctors, of course, at 32, they won't take the baby out yet. They push it, of course, towards 34. If they could complete 35, they will not push for that one. But sometimes it's not. You cannot push it anymore. The age of the baby, so we have to take them at 32. But at least somehow we know, and we have some medication, of course, to push fetal lung maturity later. I'm gonna share it with you. Okay. So preeclampsia and eclampsia. The most common medication is that magnesium sulfate, often continued for 24 hours postpartum. Okay. Why? Magnesium sulfate. Yes, sometimes it has effect, of course, to lower blood pressure, but magnesium sulfate is a major depressant. What does it do? It prevents seizures. This is, of course, an anticonvulsant that we give, of course, to the woman in order to prevent seizures. Because again, if there are seizures that's occurring to a pregnant woman, a lot of things that will be, of course, happening. Damage to her brain, damage to the circulation of the baby. Therefore, it will be advancing. That's why, as much as possible, we prevent seizures or convulsions in a pregnant woman. Okay? So the goal for that one is that magnesium sulfate. Okay? So again, you can see, of course, what are the things, of course, the signs and symptoms. So one important thing for that one, edema. Another one, of course, is the blood pressure. Okay? Just take note, of course, of the blood pressure. Okay? What is in mild preeclampsia and moderate preeclampsia? What's the blood pressure? And in your table, please.
What is it?
Mild preeclampsia.
Greater than 140, 90.
Severe preeclampsia.
Greater than 160.
Correct. So take note, of course, of the blood pressure. Okay? Because that's one of the determinant. Plus, of course, your proteinuria. So we have to check, of course, the level, of course, of albumin that is released, of course, in the urine. +1, +2, +3, +4, or +5. Okay? Besides the edema, again, you have to check the proteinuria, and you have to check the blood pressure. How high is the blood pressure? Again, management-wise, if the woman is still only in the moderate preeclampsia, the woman could go home, but the woman should be in bed rest in order, of course, to be managed by medication. If the woman borders, of course, in a severe, even preeclampsia, severe preeclampsia, proceeding, of course, to the eclampsia, we don't want the woman to go into eclampsia because in eclampsia, we have severe seizures. In preeclampsia, there might be seizures, but again, the seizures is not too much. We don't want any pregnant woman who has preeclampsia to go into seizures. That is why, if the woman's symptoms falls in the severe preeclampsia, we have to institutionalize. We have to admit the patient, the woman, of course, in the system, to closely monitor the woman and to prevent seizures. Therefore, any woman with preeclampsia is being placed into your seizure precaution. Do we know already what seizure precaution is, isn't it? Okay. But this one of the medication that was to be given is magnesium sulfate. Okay? Now here, we have also HELP syndrome. The HELP syndrome, of course, is a potentially life-threatening complication of pregnancy-induced hypertension. What are these HELP? Just imagine. Hemolysis. Without any known cause. Pregnancy-induced hypertension causes high pressure in the bloodstream, pushing the RBC and killing the RBC. Therefore, the RBC died because of too much pressure. We call that one hemolysis. Another one, elevated liver enzymes. Elevated liver enzymes happens only if we have damage to the liver. There are two primary, of course, elevated liver enzymes. These are, of course, formerly known as your SGPT and SGOT, or serum glutamic phosphoroacetic transaminase, or oxaloacetic transaminase. But right now, we know that one as your ALT, alanine transaminase, and AST. So, two most common enzymes, AST and ALT, will be elevated. It signifies only one thing. There might be, of course, occurring damage, of course, to the liver. And the last one, low platelet. If the liver will be the one who produces the platelet. If there is low platelet, there's only one thing that will happen. Platelet creates blood clotting. If you have low, what is the normal platelet level? 150 to 400,000. Okay, that's why when I check, of course, my platelet, when I do, of course, dialysis, it's below 100. If it is below 100, my thinking goes right away. If I am going to stuck the patient with a needle, with the access, I'm going to have a hard time waiting until it clots. But if my platelet, of course, will be 200, oh, thank you. Okay, 200, very good. So 2 to 3 minutes, clot right away. But I don't want, of course, the platelet to be closer to 400. Because even if we're going to pull out the blood, it will going to clot my system. Do you get what I mean? So this value, of course, is very important to me in my day-to-day activities. Before I start doing treatment with the patient, I want to know the hemodynamics, the electrolyte level of the patient, as well as, of course, the blood levels. Hematology, and we call that one hematology and chemistry. Those are the two things I want to see as a result. Okay? This one, low platelet. What will happen with this one? Hemolysis, low platelet counts, hemolysis, bleeding, of course, the patient will gonna die if it is not managed properly. That's the major complications. That's why preeclampsia, we have to manage it right away. If there's some symptoms, of course, especially the blood pressure, again, usually what we do, of course, is that we try to do, of course, a rollover test. But the rollover test is that if there's a great difference, of course, in the blood pressure. What is the difference in rollover test? Flat and then left side. Okay? Check the blood pressure of the woman when they are flat and, of course, on the sides. What is the difference?
She's eager. I mean, there's a
No, not airway. I'm checking the blood pressure to check if indeed the woman will be having a risk, of course, to develop preeclampsia.
The urine, the bladder.
No, again, I mean, the one is that is the rollover test. The rollover test is we do, of course, in a woman to check if we have possible preeclampsia. What is the increase in blood pressure? Did you read anybody read, of course, the rollover test result?
It's sure over 20 mg, 20 milligrams, yeah.
Where? Distillate, diastolate?
Diastolic.
Huh?
That's
Correct.
Yes,
Do you get it? If there is a great difference, shall we say, there's a change, of course, of 20 mmHg, of course, in diastolate, it means, of course, the woman might be developing preeclampsia. That's the earliest, no physician's orders, of course, we can check if the woman is certain. That's why, when the woman is pregnant, if they're lying, of course, in the examination bed, we try to do a rollover test on them, checking the blood pressure, because if there's a great difference, more than 20 mmHg in the diastolate, it might be the woman might be prone, of course, to develop. Okay? Okay, so preeclampsia, rollover test, blood pressure measured with client lying back on the back, that's one thing, rollover test. Mild preeclampsia may be treated at home with sedation and tranquilizer. Sometimes, that's the point, of course, that we have to give sedation in order to relax. The purpose of sedation is that to relax the woman, and another one is that to decrease the chances of seizures. Okay? So regular diet with salt, that's usually because, of course, of the blood volume. Okay? Usually, we try to limit, of course, too much salt intake in the woman because they have edema. So if the woman, if the patient has CHF as well as, of course, edema, usually salt restriction. Okay? Or else they will gonna retain more fluids. Always remember the principles later on in medical surgical nursing. Wherever salt goes, water follows. Okay? So that's the thing. Okay. Severe preeclampsia, vital signs every 2 hours, fetal monitor. So again, when do we deliver the baby? If we have fetal signs of fetal distress. Okay, that's why we have to do fetal monitor, of course, to the woman. Okay. Severe preeclampsia, low fat, high protein diet will be necessary in PO. Check urine for albumin at least twice daily and reduce external stimuli. Reducing external stimuli in severe preeclampsia, it only shows one thing. We want to prevent full-blown seizures. Okay? Now, so in severe preeclampsia, where's the patient? Usually, desirably, where's the patient in severe preeclampsia? With a specific bed. What's the location of bed? Of course, they are complete bed rest, isn't it?
Yeah.
Yes, complete bed rest for this one. But where's the location of the patient? Very good. They should be admitted in the hospital, not home. Only in moderate, of course, preeclampsia or mild preeclampsia, they could be still in home. But if they are in severe preeclampsia, they have to be in the hospital. They are already, of course, in their bed. Again, we put of course, your seizure precaution. Another one is that we reduce external stimuli. Another one is that usually they are already in magnesium sulfate drip. The purpose, of course, to prevent, of course, seizures. Okay. Now, and sometimes the woman could receive, of course, antihypertensive medication. But the only thing is that once the woman is in magnesium sulfate drip, you have to monitor the woman for possible severe CNS depression. Okay? And you have to check, of course, for the reflexes. The most common reflex, of course, is that the tendon reflex. Okay? So the thing. Put the woman in this thing, seizure precaution. Start, of course, the magnesium sulfate drip. Magnesium sulfate will relax, of course, this nervous system of the woman, as well as, of course, the muscles to prevent seizures. But it could kill the woman if you don't monitor it, because the woman's breathing patterns could be suppressed with magnesium sulfate, because that is a severely strong depressant. So one way to do that one that we know, okay, that the woman, of course, might be in magnesium toxicity level, meaning to say, of course, the magnesium is given too much, is to check not only the breathing, but to check, of course, for deep tendon reflex. So this one, patellar reflex. The woman is pregnant, you check the patellar reflex or deep tendon reflex, it is still present. Meaning to say, therapeutically, we reach, of course, the level of magnesium sulfate, it's still okay for the woman. But if you notice that there is absent deep tendon reflex in a woman receiving magnesium sulfate, it signifies one, they report it to the practitioner, because it means that we have magnesium toxicity. It will kill the woman, because again, it will destroy the breathing patterns. That's why when we are giving magnesium sulfate, another drug should be available at the bedside before the start of magnesium sulfate drip. That is your calcium gluconate. Okay? Calcium gluconate is the antidote for magnesium toxicity to reverse the effect of magnesium, to reverse the CNS depression, or else the woman can never breathe. And again, another result for cannot breathe is that their heartbeat will gonna go down. Okay, plus the reflexes will gonna go down. Okay, so calcium gluconate should be available at the bedside at the start of magnesium sulfate. That's mandatory. There's a protocol always in hospitals. And again, monitor of course for possible magnesium toxicity. What are those signs and symptoms of magnesium toxicity? Will be depression, of course, in the respiration. Okay, another one level of consciousness will be depressed, but the most common one, of course, the early sign, of course, will be diminishing or decreased deep tendon reflex. Monitor the reflexes because the depressed reflexes in a woman receiving magnesium sulfate equals magnesium toxicity. Report it to the physician at once so that antidote could be given to that woman. And the antidote for magnesium will be calcium gluconate. Calcium. Calcium.
Gluconate is
Correct.
the
Antidote for magnesium toxicity. Therefore, again, do not start. If you will be RNs, usually do not start magnesium toxicity, not magnesium drip. If you are an RN, and you're allowed to do so without available calcium gluconate at bedside. Where do we keep it? At bedside, because again, why? It will kill the woman. Right away, there's protocol even. We don't need, of course, to call the doctor because there's a standing order that if this present, you have, of course, to reverse it. Okay? Why? It will kill the woman. Not only the woman, but as well as the baby. Okay? So that's a very, very important, of course, thing, of course, to me to highlight. Then we're going to go, of course, to tonic-clonic seizures, rapid pulse. So major complications will be abruption placenta. What is abruption placenta? The uterus, of course, the placenta, of course, is disrupted or abrupted, of course, prematurely. And the worst thing is that, just imagine, abruption placenta, the placenta separated before the baby comes out. The baby is still inside, the placenta separated. What will be the result, do you think?
Fetal distress. Low oxygen, there's no support for the baby.
I don't, not only that, fetal death.
Yeah, fetal death.
Where would the baby would get? Because where would the baby get, of course, the oxygen? Because there's no placenta anymore. Or the placenta is not attached, of course, to the uterine wall.
No nutrition, no placenta.
No oxygen. Nutrition, secondary, primary oxygen. So the baby will gonna die right there and then. It will result to stillbirth, fetal distress, and then death. That's why in abruption placenta, depending of course on the percentage of abruption, the baby that's one of the most common indication of stat right away, C-section. Okay? This is the time, of course, that all the elective surgery should be removed out, of course, from the OR and replaced, of course, for a woman with abruption placenta. Okay? DM. Three things, of course, management for DM, as we know, isn't it? Insulin or medication or over hypoglycemic agents, exercise, and diet. What if the woman who has a long-standing DM, okay, is pregnant? Therefore, again, the answer will be they have to keep the insulin because there is fluctuation of course, of the blood glucose level. Therefore, keen observation, of course, of the blood glucose will be very, very important. Because again, if you are diabetic, could you get pregnant? Yeah. Yes, you have all the right in the world. But again, there is a diabetic woman pregnant. Is a pregnant diabetic woman high-risk pregnancy?
Yeah.
Yes.
Definitely, okay? So that's why, common practice, if the woman has type 1 DM, they're insulin dependent, we never alter the insulin. We closely monitor the insulin, and the sliding scale might be, of course, controlled or titrated closely. If the woman is diabetic, the DM type 2, wherein they are maintained of oral hypoglycemic agents, okay? Usually, during pregnancy, that oral hypoglycemic will be cut off or stopped, and it will be replaced by insulin. Only insulin could better control the glucose during pregnancy, okay? That's why it's very, very important. Need special care and monitoring during pregnancy.
So after the childbirth, we should be back on the oral.
If the blood sugar, of course, doesn't go back, after, of course, the woman, of course, is that oral hypoglycemic, the DM type 2?
Yes.
Usually they go back, of course, to oral
like
hypoglycemic.
okay.
Only the entire pregnancy.
Okay.
And this one, of course, monitoring. But again, some women develop DM during pregnancy. You are normal right now, your blood sugar. Once you get pregnant, you develop what it calls the third type, of course, of DM. We call it one gestational diabetes. Gestational diabetes, of course, is a woman whose blood sugar, of course, increases, of course, during pregnancy. Okay? Gestational, that's one thing, of course, that sometimes we have to check on the 6-week time frame. Usually. If the blood sugar is not yet altered, of course, the woman during the time, it's still not balanced, it will go back, of course, to normal, the woman will be of course, diagnosed with DM type 2, no longer gestational DM. Because gestational DM, after pregnancy, for the first, and the 6 weeks, the woman's blood sugar will gonna go back, of course, to the normal level. But believe it or not, a woman who has a gestational diabetes has 60 to 80% chances of developing DM type 2. Okay? The main problem if we don't manage it, if we give a lot of blood sugar, remember, if the baby is healthy, the baby's pancreas is producing insulin. So again, insulin is being, of course, produced in response to the level of glucose in the blood. Okay? So if the mother's system is not monitored properly, is not managed glucose properly, so again, the glucose level also, of course, in the circulation of the baby goes high. So what if the baby, of course, has a normal pancreas, the baby's pancreas will gonna produce more insulin, isn't it? So because of there is more insulin, more glucose is absorbed to the baby. Therefore, the baby is absorbing all this glucose. So what will be the result of the baby? The baby is a giant. Okay? We call that one as your macrosomia or oversized fetuses. Okay? This is, of course, we call that one an oversized baby. And usually, an oversized baby is above the 90th percentile of the expected birth weight. Because of that one, it's very hard to deliver a baby who is a macrosomic. Most common problem, the head cannot pass through, of course, the pelvic inlet. Okay? CPD. Fetus with respiratory disorders is very common and difficult labor because, again, the baby is so big. If it will allow to, well, sometimes it's a big problem because the baby cannot pass through. If you allow normal labor, sometimes the baby doesn't go down or descend because, of course, the fetal head is very big. Okay? And DM, as we have said, of course, that preeclampsia is the most common one. Polyhydramnios, the fluid is greater than 2 liters inside. Okay? So we need to say the abdomen is so big, and of course, the risk, of course, for a lot, of course, in polyhydramnios. Congenital malformation, hyperglycemic. So sometimes if the woman is diabetic, diabetic type 1, there's a possibility that the woman could go into acidosis or diabetic coma. Okay? Hypoglycemia, fetal hypoxia. So we deliver early 36 to 38 weeks by induction or C-section, depending, of course, if we don't have any fetal distress. Fetal distress is the key, of course, to tell when to the woman. If the baby is, of course, is in fetal distress or the fetus is in fetal distress, right away is indicative, of course, that we have to remove the baby out right away. Or else, if we don't manage fetal distress by delivery, the baby will die. So pick one. So we have, of course, to remove the baby out. So the reaction, of course, to the only problem in babies, we're going to talk the babies later, is that a macrosomic baby or babies born out of diabetic mothers without any good control of blood glucose, the problem is that their insulin is very hard. Your pancreas are so big and enlarged, and they produce more insulin. When they go out, okay, right away, if you cut the cord, the baby doesn't have any source of glucose. Right away, right there and then, in the first few minutes of life of the baby, the first 2 hours, the baby will gonna go into a massive case of hypoglycemia. Okay? Because again, why? More insulin, no glucose source. What will happen? Hypoglycemia. Because again, the glucose will be the one to absorb, of course, all the glucose from the bloodstream. That's why a macrosomic babies or a baby, of course, born of diabetic mothers has to be monitored right away. We have to do a health stick blood glucose right away in the first 2 hours to make sure that the baby is not hypoglycemic. If the baby is hypoglycemic, then we have to give early glucose water to the baby, the first suck, in order, of course, to manage hypoglycemia. So again, those are the high-risk newborns. So that we're going to talk, of course, as we go along. Okay? The woman's body reacts to trauma in birth and their glucose level is easily upset. So again, one thing is that the most important thing is that whether type 1 or type 2 DM, we have, of course, to make sure that we have self-testing for blood glucose, insulin and diet adjustment based, of course, on the glucose level, and method, of course, of insulin injection to the one that's not used insulin previously, if the woman has only type 2 DM. Okay? So signs of hyperglycemia, hypoglycemia, and the I've said is that, what is the great difference between hyperglycemia and hypoglycemia? When the skin is warm and dry, the sugar is high. Isn't that? When the skin is cold and clammy, the patient needs some candy. Therefore, that's hypoglycemia. Action to take hyperglycemia or hypoglycemia occurs in signs and symptoms of beginning, of course, of preeclampsia, because again, non-managed, of course, diabetic mellitus. And again, in reality of life, believe it or not, If a patient is diabetic, not only pregnant, if you are diabetic, the next thing you expect, of course, to come into you is hypertension. If you are hypertensive, I call this hypertension and diabetes mellitus are brothers and sisters of different fathers, of different mothers. Because why? Once you have hypertension, manage, of course, your blood glucose level, because eventually you will develop DM type 2. And if you have DM type 2, the half brother or half sister will gonna come and join. So DM, if you have DM, of course, DM, you don't have any hypertension, you expect that one. If you have poorly managing, of course, your blood sugar, hypertension will occur. And DM, diabetes mellitus, and hypertension are the two most common cause that will destroy your kidney totally. So for my patient who are of course end-stage renal failure, who has zero renal function, most of them are diabetic and hypertensive. Diabetes is the number one cause, of course, of end-stage renal failure. Gestational diabetes, 4% of women manage diabetes for some. Others requires insulin. Sometimes, to upset, of course, the system, even gestational DM, we have to maintain it, of course, with insulin. Okay, majority return to pre-pregnancy glucose level. Gestational diabetes mellitus in women who have delivered a baby weighing more than 9 pounds known to have developed DM type 2 later years. Advise the possible risk. Okay, so majority return to pre-pregnancy glucose levels after delivery. But again, the risk, of course, to develop DM, full-blown DM type 2 is very high. Okay, cardiac disorders. What are cardiac disorders? Women who has problems with the heart. It is not psychologically that they are emotionally upset. No. Physical problems, of course, with the heart. The most common problem here is that cardiomyopathy. And the most common problem correlated, of course, to pregnancy are that women with congestive heart failure. Okay? In congestive heart failure, there is backflow, of course, of the blood. It means to say that the heart is not strong enough to support the pumping needs of the body. Okay? So as for dyspnea, dyspnea is the most common one in CHF even. How much more, just imagine, if the heart cannot meet the needs, of course, of the body, what if the woman is pregnant? Think about it. It's very, very hard, of course, for a woman who has CHF to get pregnant. Does it occur spontaneously? Yes, it does. So that's why these are the two things sometimes in myth and telenovelas you say, the husband was given, of course, the choice to save the baby or to save the mother. Okay? And the correct answer will be both. Nice, isn't it? But these are the most common things that they were given a chance, of course. Who would you like to save, the baby or the mother? Gosh, it's a very bad thing, of course, to choose, isn't it? Even it's early pregnancy, usually, of course, the husband will gonna choose, of course, the wife. So, well, you can abort that one. That's why this is the most common victims, of course, of abortion, therapeutic abortion, because the woman's system cannot afford, cannot carry, of course, the entire pregnancy. If you allow, of course, CHF, of course, if you allow pregnancy to happen in the advanced CHF, then the woman's body will gonna die, and the woman will die, and the fetus will die. Okay, so pick one. So usually they're not very conducive, of course, for a thing. But again, pulmonary edema during labor occurs. So dyspnea, chest pain, pulmonary edema are signs and symptoms of advanced CHF. Okay, during pregnancy, adequate rest. Because why? In patient even with CHF, we don't want them to exert, because exertion requires more pumping of the heart, requires, of course, stress to the heart. Avoid activities that result in shortness of breath. Diet that prevents excessive weight gain. That's why CHF in women with cardiac problems will restrict salt. They are salt-restricted diet. Okay? Sodium salt restriction is very important because, again, they have CHF and they get pregnant. But if they get pregnant, they are closely monitored. Okay? Prognosis depend on the age. In the younger population, chances are high. And the severity and type of the heart disease. If they have far advanced CHF or cardiomyopathy, usually the chances, of course, of making it through the entire pregnancy is very low. That is why one option will be, of course, abortion for them before the pregnancy. But sometimes, remember, the woman will be deciding. So sometimes the woman will gonna gamble. She wants to give, of course, a child to the man. So if that will be the case, of course, she will gonna gamble. Sometimes it is closely monitored. Sometimes she will be successful. Sometimes they both die. Or sometimes they develop, of course, a complication that only one was saved, actually. It's not the mother, it's only the baby. Okay? So this is a hard thing. But this is a cardiac problem. Chemical dependency. What will be happening towards the pregnancy if the mother is addict? Well, the word addict is not no longer used, isn't it? Because if you're an addict, what kind of addict? Sex addict or drug addict, isn't it? Or addicted, of course, to iPad, iPad, okay? So everything technological savvy or technologically addict, okay? So here, of course, is that the term that we use for that one is that drug abuser. That's the technical term that we use, okay? Or drug user. Malnourished, no under parental care. So again, a lot of women, of course, who are chemical dependent, usually, of course, we're gonna use their body, of course, they're gonna use, of course, their body to acquire, of course, the chemical, isn't it? The drugs. And in the event they get pregnant, and they get pregnant, they don't care because again, psychologically and physically, they are so dependent with the drug. Okay? It could result to stillbirth, meaning stillbirth, the baby died after 20 weeks of gestation inside, and then before it was given birth. Spontaneous abortion, abruption placenta, to name a few, numerous congenital defects. Okay? Mother often lacks parenting skills. That's why if they are born to a chemical dependent mother, usually a court order will be given to the mother. They will be, of course, advised to the court, of course, that the social welfare will gonna take the baby with them, and then again, the woman has to prove herself was to be clean and to undergo rehabilitation before she can take custody, of course, of the baby. Okay? So that's one thing. Child protection authorities should be involved early in the pregnancy to guide, of course, the woman. Okay? The woman has to present, of course, a successful rehabilitation, plus, of course, psychological and emotional readiness, of course, to be a parent before, of course, she will be allowed custody of the child. Okay? That's one, of course, the most common story. Sometimes this woman go back into being an addict again. So what happens? These are the babies that you have, of course, a tendency to adapt. Okay? Now, we have been talking infection. Okay? Infection, anything, of course, infection. It could be, of course, infected, of course, through, or probably the woman might be infected or is having infection. So another one, of course, is that the baby, of course, could be infected. Another one problem is your RH sensitization. So we talked about this one. Okay? So we understand deeper. This is a very interesting concept, of course, to understand. But again, only, of course, not very large amount of women are RH negative. So that's why, if you are a woman, your advice will be, of course, my advice, of course, for women who are trying, of course, to have babies or at risk, of course, to have babies, to be pregnant, make sure before first pregnancy, know your RH status. Get a blood type. It's just easy. Get a blood type. Because your blood type will tell you if you're RH positive or not. And usually, you know it. Okay? So, do you know your blood type? Women. Avani, what is your blood type? Good. That's a very, very good type. This is a very good blood type, of course, for a woman to get pregnant. That's a very desirable, of course, blood type for reproductive purposes. We don't like, of course, especially what blood type. Later on, we're gonna know. And we don't want, of course, women, of course, to have O. Usually we don't, especially O negative. Or even if you're A negative, you have a big problem. That's why we have, of course, to do raw gum. Do you know your blood type? Do you know your blood type? I'm sorry, you have to check it, Missy. If before, of course, you get, of course, your first pregnancy, if you're planning to get pregnant, if you don't have any child, okay? That's my advice, because again, you will know. You will destroy your potential reproductive only for one baby. That's why it's very important. Baby, you know your blood type. What is yours? See? So majority of you here, hopefully, of course, there's no negative here. So I believe, of course, probably barely, of course, the chance of O negative. But if there's no O negative, you know what to do. Be careful, of course, when you get pregnant. Okay? So, but most common, the entire population, majority, 80 to 90% are positive. Okay? Only few, but if you are negative, then there's a big problem. Okay. And the third for the one is that when the mother's antibody is destroying the baby is known as your erythroblastosis fetalis. Why erythroblastosis? Because the erythrocytes is being, and the blastocyst, of course, of the baby, of course, that's being produced, is being destroyed while they are in fetal life. Okay? This is what we call it erythroblastosis fetalis. Okay? Meaning to say, of course, their RBC is being destroyed by the mother's antibody. So again, efforts to save the baby, I've been talking about, someone newborn badly affected, especially if it's the first case. Others severely affected. Efforts to save the fetus, intrauterine transfusion. This is what I'm talking about. Exchange of fetal blood in the utero in pregnancy is less than 32 weeks. As much as possible, we want to push it to be closer to 35 weeks because of fetal maturity, fetal lung maturity. So sometimes we do that one. Or if we cannot save any of the babies in distress, early delivery between, of course, 34 to 38 weeks. As much as possible, the mandate will be push it towards completion of 35 weeks. Clear. Again, the rule will be, if the baby will be delivered prematurely and we cannot avoid that one, we want the baby to complete 35 weeks because at 35 weeks, we have lung maturity already established. Meaning to say, the chances of survival, the baby or lung problems will be lesser. Okay. Administer anti-ROGAM D, also known as your ROGAM or Gamolin RH, is another brand name, to women, normal pregnancy, 28 weeks, or in any event of possible bleeding in amniocentesis or any procedure that might possibly infuse fetal blood to the mother's blood. Spotting any bleeding or any invasive surgical procedure, just like amniocentesis. And again, repeat that one, or again, not only that one, but in any event that the woman has abortion or miscarriage. Okay? And another one, if for successful pregnancy that resulted to term delivery, so we have to give, of course, another ROGAM within 72 hours of delivery of that baby. Okay? That's the goal, of course, for this one. Because again, why? If a woman is sensitized, it will destroy the baby, poor baby. It's not the baby's fault. Okay? It's not. So sometimes you are not given a chance. And again, the baby is not abnormal. It so happened, of course, that the blood type of the baby is Rh positive, which is, of course, 90% of the population. The only problem is the woman is Rh negative. So that's one thing. Okay. That's Rh. We understand that one. In each time an Rh negative woman delivers or aborts a baby, ROGAM is also administered. Again. Now, ABO incompatibility. So, hemolytic disease, these are another problem. So that's why you have to know your blood type. Because you have, of course, to know, of course, the baby's blood type. ABO incompatibility, of course, will be, again, the manifestation of Rh and will be, of course, commonly is that there will be jaundice in the baby before 24 hours. But here in ABO incompatibility, meaning to say the baby's blood and the mother's blood are incompatible. So it might not, there's nothing we can do about this one. But again, the manifestation of this one is a lesser degree. So we can do a lot of these things when the baby, of course, comes out. Will it kill the baby? Not necessarily. But will it cause, of course, problems, of course, with jaundice? Yes, it could. But again, this is, of course, a mild form of incompatibility. And there's nothing we could do. And usually doctors doesn't do anything unless the baby comes out. Okay? It's not detectable before birth. So problem here is that mother is A and fetus is B or AB. Okay? So again, commonly mother is B and the fetus is A or AB. Mother type O and the fetus is A, B, or AB. That's why I don't like the mother to have O. Okay? So now the question will be is that, what is the problem? Which blood type, of course, of the baby in the woman, of course, that you're going to have a problem and don't? Example. So and how do we understand this one? In the first place is that if you are giving blood, of course, and receiving blood, we know, of course, that the blood type that could receive any blood type is wrong. AB. AB is the universal recipient.
O is the only one that can get O.
O is the universal donor. So again, to understand that one is that, if you have a blood type AB, there's another thing. If you have blood type AB, then you're going to receive any blood type. Except, of course, now I'm not talking, of course, the Rh factor. So if you have AB, could you receive, of course, any AB blood type? Yes. Therefore, if you are a mother, I want you to be an AB. The best, of course, and desirable, of course, blood type for a mother will be AB. Because again, whatever, of course, the blood type of the baby, you don't have any problem. You're always compatible ABO. Okay? So in the blood type O in regular is that you can give to any blood type. Because an O, again, we speak, of course, of A and AB, we are talking, of course, here, of course, on the antibody it contains. A blood type A contains, of course, antibody against A. A B contains antibody against B. AB, of course, antibody against the antigen, what I mean, antigen. And then if you have a blood type O, you don't have any antigen. Okay, so again, antigen, blood type A, you contain, of course, antigen A. Okay? And you have antibody against B. But don't forget about antigen. You process this antigen. If you have blood type O, you don't have any antigen. Therefore, if you don't have any antigen, you're going to create, of course, a blood reaction. Therefore, blood type O could be given to anybody. If you have blood type AB, you have antigen. So blood type AB could only be given to AB. But the AB doesn't contain any antibodies. Therefore, it could receive any blood type. Clear? So if you have blood type A, to whom could you give?
O.
A.
Nope. You cannot give to O.
To B.
But if you have you have blood type A, to whom could you give?
AB.
Very good.
Yeah,
What
A
else?
and AB.
Very good. A and AB, isn't it? If you have blood type B, whom you could give?
A to
A, no, AB, of course, if you have blood type B. Where, to whom could you give? To whom donate?
B and A.
B and AB, isn't that? If you have blood type AB, to whom could you give?
AB. Only AB.
Only AB. My question is that if you have blood type AB, to whom could you give?
Only AB.
Only AB. Do you get it? Now, if you have blood type O, to whom could you give? A? What are those everybody? A, AB, B, and O. Do you get it? So if you have blood type O, you can give any. Now, I'm going to reverse it. If you have blood type A, to whom, what blood type could you receive?
O and
B
AB.
and
Very good. A only and O. Do you get it? If you have blood type A, what blood type could you receive? A, not AB, because AB is, you cannot give AB to other else, only AB. So only blood type A can receive. If you have blood type A, you can receive from O and A. If you have blood type B, B and O. If you have blood type AB, AB and O. If you have, of course, blood type O, only O, nothing else. Do you get it? Okay, now, how do we understand if there is a problem or not? Simple. Think the baby is the donor. Think the baby is the donor. Do you get it? The baby is the donor. So the best blood type for the baby will be? Very good. So if the baby is O, then we don't have any problems, isn't it? And the best blood type for the mother will be?
AB.
That's why. Now, I'm going to give you a scenario. Mother's blood type O. Okay? Baby's blood type O. Problem or not problem? No problem. No problem. Mother's blood type O. Baby's blood type AB. Very good. Okay. Baby's blood type O. Baby's blood type O and of course the mother's blood type AB. The baby's blood type is O and the mother's blood type is AB.
Oh, the baby can give the blood.
Do you get it now? I want you to think that way. Baby is the donor. If the baby is O and the mother, of course, I don't care what the blood type, the baby, of course, could give. So if the baby is O and the baby is AB, do we have a problem? No. If the baby, of course, is A, if the baby is A and the mother is A, no problem, isn't it? Okay. So what if the baby is A and the mother is AB? Do we have a problem or not?
Yes.
Do we have a problem, of course?
No.
Yes.
Do we have a problem if the baby is A and the mother is AB?
No.
Yes.
Yes, because
Because
you
you
can
can only
receive
receive A
blood
and
from
O. If you are
the mother-
the baby, if the baby.
The baby is the donor.
Yeah.
Think about it. Mother is AB and the baby is A. Do we have a problem? Who is the donor here in this condition?
The
The
baby.
baby.
So what's the baby? Blood type.
A.
And the mother is?
AB.
Could we give A to AB?
Yeah.
So where's the problem? So that's the other things, of course, I want you. No. This is the thing, of course, I want you, because it's very confusing. So the one way to think about is that to master, of course, the blood where to give. And always to think what the baby, of course, blood type. And the baby's blood type will determine, of course, if you can give it to the mother or not. That's why I said, if the baby is O, you don't have any problem about this one. If the mother's blood type is AB, you don't have any problem, just like this one. Okay? So, but again, the question will be, is not AB or AB. If the question, of course, will be just like this one I've said. If the baby, so I'm saying, if the baby is AB, and the mother is O, do we have any problem? Do we have a problem if the baby is AB, and the mother is O? Who is the donor now? No, the baby is still the donor. That's why I think it that way.
Baby is a donor, so she.
Baby is always the donor in this incompatibility. So now I'm saying, of course, the baby is AB and the mother is O. Do we have a problem or not?
Yeah.
Yes, because you cannot give AB to O. Do you get it? I want you to master the one because again, I'm gonna go deeper for that one, of course, when we go, of course, to your hematology, the medical surgical nursing. Okay? But I try, of course, to simplify for you, of course, to appreciate, of course, this one. Now, if sometimes the problem, of course, for both RH, if the baby is born with erythroblastosis fetalis, we call it one, of course, babies who turn up to be have a massive jaundice. Jaundice or hyperbilirubinemia could only be normal in a child, newborn, if it develops after 48 hours. But if the hyperbilirubinemia or jaundice occurs and develops in a newborn less than 24 hours, it is a problem. It means, of course, that we have hemolysis. Either it is secondary to RH incompatibility or ABO incompatibility. Okay? So usually clinical milder than RH sensitization indicated by jaundice in newborn within the first 24 to 36 hours. But usually, if commonly, of course, normal jaundice will occur in the 72-hour period. So that's why in Africa or in Asia, you can see babies that are yellow a little bit. How could you say even if they are dark color, the sclera of the eyes becomes yellow?
Mine already got it.
You got that one? So did you have Billy Light, of course, for your baby? Or Billy Blanket? Goes with the baby? When did it occur?
After 2 days. After I went home. It's like third day.
Third day. So that's your physiologic jaundice. Is it normal to have physiologic jaundice on the third day? Yes, indeed. Because there is, of course, rapid destruction of the baby's RBC on the third day because there's too much. Only if it occurs, of course, technically after, of course, 24 to 48 hours. To be specific, for it to be healthy, it should be 72 hours. But any jaundice that developed in a newborn before reaching 24 hours is a big problem. Okay? It requires intervention. So indicated jaundice will be phototherapy. That's why we put them under a Billy Light. What is Billy Light for? Bilirubin light. So what if, Jones, what if the baby is born, of course, there's no electricity, you don't have any Billy Light, of course, in your village or in some village that you know from? So what do we do there? Very good. That's why we open the babies, of course, in sunlight early morning before 10 a.m. Clear? Then why I said so? Because sunlight between the times of 11 to 4 is carcinogenic. I'm going to talk to you, of course, to that one in skin disorders. Okay? So that's why before 10 o'clock I said so, because that's the healthy we're in, it is therapeutic. The sunlight is therapeutic at the time. Okay? So we have to present it to the sunlight. That's why we dry it. But don't put, of course, after 10 o'clock up to 2 o'clock, or else the baby will be a dried baby. Okay? It's no longer dried mangoes, dried fish, or the hair is a dried baby. So we don't like, of course, to happen. Okay? Another one here in the United States of America, we're so particular, we have advanced. So one way is that the babies will be discharged with a Billy blanket. A Billy blanket, of course, it produces light to reduce, of course, why? Bilirubin, of course, that goes in the skin could only be enhanced to be absorbed by the liver to be conjugated if it was presented to a sunlight. Sunlight or Billy light will be important. That's why Billy light, meaning to say a Billy light, we could put the baby there, or a Billy blanket. So usually we discharge the baby with a Billy blanket to put, of course, underlying, of course, their crib when they go home. If it's only, of course, manageable at home. Okay? If not, presenting, of course, to sunlight could be done, especially it's being done, of course, in a lot, of course, of places where you don't have any Billy blanket and Billy light. Okay? The only problem for that one is that if you're born during rainy season, there's a problem, isn't it? So there's no much sunlight, and you're going to take so, of course, to sunlight, of course, eventually. So another problem here, of course, is your placenta problem in your amniotic disorders. Now, previa. What is previa? The location of the placenta. Where is the desirable location of the placenta?
The placenta is up in the cervix.
Up, above, or towards the fundus. Okay, because why? Towards the fundus in the upper third, of course, of the uterus, that is the thickest part. Therefore, if they were going to try to bore to implant, that's the best way, of course, to implant, because they could suck the best blood, of course, from the mother. Now, as you go along, as the uterus grows down, it becomes thinner, the layer. So if the implantation of the placenta will be low, one problem will be, it is not gifted with a lot, of course, of blood supply, therefore the baby will be having restricted blood flow. Another one is that, later on, in order to seal off that layer, if there's no muscular layer of that area, there will be difficulty, of course, to close the ducts, of course, especially when there's placental separation after childbirth. Bleeding will be a major problem. But first, the major problem in placenta previa will be there will be no enough nourishment and oxygen for the baby. So placenta implants in the wrong place within the woman's uterus. we don't want it towards the neck, we want it towards above. Okay? So that's one thing. And sometimes, the question will be, how low is low? Sometimes, your problem will be in the placenta previa, or also known as your low-lying placenta. Another one is abruptio placenta. Placenta separates prematurely. The most common part of that one is that it of course disrupts, tears away of course from the uterus while the baby is inside. The baby will die. You have to take out the baby. Hopefully, of course, the age of course of the baby is about 20 weeks AOG. Okay? Both may be life-threatening to women and fetus. Another one will be your polyhydramnios. And polyhydramnios, excessive amount of amniotic fluids, of course, serious danger, of course, to the baby because the baby cannot move and the pressure inside will be very, very high. Just like the baby is being compressed in a high pressure, of course, amniotic fluid because the volume is too high. Okay? So again, placenta previa implants in lower segments, of course, of the uterus rather than in the upper wall. So we call it one placenta previa. This is the normal one. We want the placenta to be here on the side. So you can see, of course, this is the layers. The other layer, of course, will be the amniotic side in the chorion side. So the chorion will be the placenta. This is the implantation. And of course, inside, of course, the amnion, the baby will gonna grow. The embryo will gonna grow. That's the placenta is here. Okay. This is, of course, your amniotic fluid, the amniotic membrane. Here is a low-lying placenta. Okay. So the only problem for that one is that placenta previa, one of the significant changes for that one is that during pregnancy, there will be spotting. That's why, again, during the entire pregnancy, I don't want to see any blood in the woman. I want to see the blood only if the baby is term. It means to say that there's a blood to show. Cervix, of course, has been dislodged, of course, with the plug, and now the woman is ready and the baby is ready to come out. But during this time, we don't want to see any blood. But trickles of blood will be just like this one. And this one, of course, will be occluding, of course, entirely, breech presentation. And this one, of course, is a complete placenta previa. Now, the question will be, could we deliver this one, of course, vaginally, spontaneously? The answer might be yes, if, okay, the placenta here that covers the cervix will be less than 30%. 30%. The number will be 30%. If the condition persists, of course, that just like this one, if it's more than 30%, or just like this one, almost 100%, of course, of the entire placenta is on the cervix. This too, which is greater than 30%, should be done C-section. Okay? If not, if that will be the case sometimes, we have to do, of course, what we have to do is that we have to do a double setup. Okay? What is double setup? The doctor will deliver the baby. First bed will be, of course, the normal spontaneous delivery. The other bed is C-section. We try, of course, to do this one if we could do. If not, we do, of course, C-section. Because again, why? This is the risk, of course, just like equivalent to abruptio placenta. Because again, why? The placenta will be delivered first. If you remove the placenta while the baby is still inside, the baby will gonna breathe. If the baby will breathe, of course, it will destroy the lungs. Okay, so fetal distress equals fetal death. So that's the thing. So again, but the rule technically would be less than 30% of the involvement, of course, of the cervix is covered, of course, by, what is 30%, of course, of the cervix. But if the whole cervix is covered by the placenta, forget about it. And plus the fact, of course, if this 100% just like this one, remember, this portion, of course, of the uterus is very thin. The worst scenario, this one is that even if they remove, of course, the baby for this one, okay, out of course C-section, this, of course, area has to crump and contract in order to close the open veins. So again, in that layer, of course, is usually, of course, very thin. It will gonna end up, this is the risk, of course, of very high bleeding chances. That is why commonly, if this will be the condition, when the baby is delivered this way, the woman has to decide. Usually, if it cannot clot or it cannot stop bleeding, usually we have, of course, to take down the entire uterus. We call it one, of course, as your emergency hysterectomy. So if you remove the uterus, could the woman still get pregnant next time?
No.
Of course not. You don't have any uterus. Well, you get pregnant in the throat. What I mean is that if we remove the entire uterus, could the woman get pregnant? Definitely not. But could the woman have sex? Definitely. Enjoy. Tell the husband to enjoy. Because there's no possible risk, of course, of pregnancy. Okay? It's hysterectomized. Because why? If you don't cut it, the bleeding will be high. It will kill the woman.
Do they still have periods when the uterus is removed?
Of course not. How could you remove? Well, you have to cut it off. So again, remember, if you cut it off, where would the baby get the breathing? So the first thing is that we have to cut off here, remove the baby out, clamp the cord, baby healthy, baby of course this one. After that one, we have to remove placenta. The degree of course of this one is sometimes is that it will be checked of course of the doctor. The doctor could gamble. They have to put of course a packing on this one to prevent further bleeding. But in the event of course that bleeding continues, they have of course to open up the woman again and take down the entirety of course of the uterus. Therefore the baby is no longer there. The baby is already in the neonatal ICU.
So she says
I'm
that
asking if
do
they
they
still
still have
have the
menstruation
menstruation.
after they remove the uterus?
Oh gosh, you know what? I'm so scared with that kind of question.
No.
Where would the menstruation comes from?
No.
Now understand what is menstruation. You're scaring me. You're scaring me with that kind of course of because of course that question could only arise to know what is menstruation all about. Menstruation, okay, is the tissue that sheds off here in the uterus, okay, when there's no fertilization, when there's no implantation occurs. If you cut off, of course, the uterus after the delivery, there's no more menstruation. We call it one, of course, as your surgical menopause. So meaning to say, that's my question later on in reproductive health or reproduction. Could a 20-year-old woman possible to have menopause? The answer, yes. If you take down, of course, the uterus, there's no lining, of course, to bleed, to be inducted, of course, by the hormone. We call that one as your surgical menopause. Meaning to say, if you don't have uterus, you don't menstruate. So if you don't have uterus, you don't even pregnant, where would the pregnancy go? There's nothing.
Oh, that's nice.
Okay? But could you still ovulate? Yes, you could ovulate. The only problem for that one is that where that it goes. The menstruation is not, of course, relative to the egg. Menstruation is relative to the layer, the thickness, of course, of the endometrium, which is being prepared by the hormones in order to make sure that when the egg is fertilized, it has a thick cushion to implant. So if you don't have any uterus, no menstruation. So usually is that, we cut this off and close it here, still the husband is still the vagina. Could to further questions of some students, of course, before is that, Mr. Lear, could the woman still, of course, enjoy orgasm? Definitely, because we didn't remove the G spot. So whatever that will be, okay? But again, they could engage in intercourse, they could enjoy sexual intercourse, but again, they don't get pregnant. That is only for hysterectomy, okay?
Excuse me. Can you say again the double setup?
Double setup meaning to say, of course, that when we speak of double setup, we tried, the doctor will gonna try to deliver it vaginally. And any risk, of course, that is presenting that there is the risk for bleeding or complication, the woman, of course, will be, of course, the other table will be pushed, of course, and the woman, of course, will be, of course, subjected to C-section. So when you speak of double setup, so usually the instruments on the other side will be, of course, for normal spontaneous vaginal delivery. The other table, of course, will be your C-section. Okay? So what is? Could we read? No. Complication arises. Okay, push, of course, the normal spontaneous delivery things. So again, they were gonna, of course, grab, of course, the table, of course, for the CS section and change, of course, the location and slit the woman.
I thought you gonna do C-section for the baby and
No.
then the placenta is vaginal.
If we do, of course, then we have to remove, of course, it. The good thing about it, we could feel, of course, if it is bleeding or not. But again, the lochia, if the woman is C-section, you still have to monitor lochia. Because lochia should go out in the vagina, not in the, of course, in the drains of the C-section. That's why delivery is the method, of course, of removal of the baby out. Okay? But still, of course, placenta, of course, will be removed, of course, at one in order to make sure, of course, that everything, of course, will be removed out. Once it is in the suturate, you still have to monitor, of course, the lochia vaginally, even if it's C-section.
Wait, once you have a hysterectomy,
Mm-hmm.
okay, I'm not quite sure about the anatomy still. Would there be still a chance of ectopic pregnancy or?
Very good question.
Yes.
Very good question. Isn't it? Well, my question would be that pregnancy result, of course, in the union of a sperm and an egg.
Yeah.
You have, of course, the thing, of course, that again the egg will be released from the ovary. Now there's still fallopian tube that is hanging there.
Everything is still functional except for the uterus.
Now my question with you is that where would the sperm pass?
That's that thing I'm not sure about.
Okay, now introduce the sperm. Where would the sperm pass?
No, uterus.
Would it still be connected to the fallopian tube or the
There's no
back is
connection. You remove this one. If you're gonna go back to the anatomy and physiology, is that's supposed to be a very good hypothetical question, but the question is that it goes back, of course, to the anatomy itself. Okay? I'm gonna show you why could not it be possible. Why it is possible. Vagina, cervix, uterus, okay, the uterus, membrane, egg, membrane, fallopian tube, egg on the other side. Not egg, ovary. Okay? Imagine, I'm gonna take down, of course, the entire uterus. Cut this off and cut this off. So I cut this off, I cut this off, I cut this off. The remaining thing is that the vagina. Could they have sex? Yes, it go. But again, introduce the sperm here. Where did the sperm pass? This is closed because we had surgically closed it.
But you have a slight chance.
What? How is this the chance? It's closed. There's no opening.
Isn't there 0.05% chance to get pregnant after getting hysterectomy?
No.
Ectopic pregnancy?
Now my question for that one will be is that, is it even possible, biologically possible for the sperm, of course, to meet the egg? Now my question would be, where would the sperm pass?
I think she's talking about ectopic
No.
pregnancy, not.
No, zero.
No, sir.
Because my question will be for you is that, in order to be possible is that, where would of course the sperm pass to meet, of course, shall we say, at the end of course of pregnancy, again, egg will be spread here. Egg is very small, so if this is closed,
Okay, so just
this is closed, surgically closed, cut off, closed, it healed. Cut off, closed. Where the sperm pass? Even if you swallow the sperm, how good, of course, the chances of the sperm not destroyed with hydrochloric acid? And how could it go, of course, outside this cavity and get in this one? They have no direct part. And again, sperm cannot penetrate, of course, the blood system or the hematology. Now, my question with you is that the very good question is that, technically, hypothetically, it could be. But my question will be is that before, of course, pregnancy could occur, there should be fertilization. What is fertilization? The union of a sperm and an egg. Where in the heck would the sperm pass? Answer me that question.
But tube side is not 100%.
You are talking for me, of course, again. You are talking about different things. Tubal ligation. In tubal ligation, it's different thing. We still have an open cervix. We still have an open. It might be tied. But there's a possibility that the sperm could penetrate this one. But again, in the first place, sex, ejaculation of the sperm, we still have, of course, the intact, of course, uterus wherein the sperm could pass. This is, of course, tightened. There's a possibility, yes, that is the risk that pregnancy could occur, but not in hysterectomy. My God.
I was getting confused.
That's why. You have to know your anatomy. This is the power, I tell you. I beg you. If you master your anatomy, you understand the perspective. Do you get it? That's why I beg you, of course, to master that layer, because it is very important for you. When I went into my nursing school, the trick will be I didn't understand this one until I mastered, of course. Not mastered, but I have a good grasp of anatomy. So the question here is that hypothetical, where the sperm will gonna pass in order, of course, to have ectopic pregnancy, fertilization should occur. Where does the sperm will pass? Because if the sperm has to pass this one, I don't know if it could pass even because this is scar tissue. If the sperm could pass at one, then remember, if somebody ejaculated in your skin, you might get pregnant. You get what I mean? That's the possibility of it. If you're a woman. And I'm trying, of course, to be direct at the point to appreciate the perspective. I think the positive in your tubal ligation, if it is only tied, there's always the chances to get pregnant. Therefore, documentation-wise, there are some women, of course, who had tubal ligation before they get pregnant. I could attest to that one. Because again, depending, of course, on the method. That is why later on, and right now, the most common one, of course, that we are doing in tubal ligation before, the best way, of course, to do that one is that we cut this off. We cut this off. We cut this off, and then after that one, of course, we put, of course, layer on the top of each other. Okay, and then tie this up. But right now, what we are doing is just cut this off. No. Right now we have to tighten this up. And right now is that we have technology already, of course, because of course of microvascular technology. If you have been tubally ligated before, could you reverse the tubal ligation at this point in time? The answer is yes.
Is it only within 5 years or is it any time?
As long as you don't cut the thing there and there's no total closure, there's always possibility. Although the chances, of course, of successful will be within 5 years being done. Okay? Amazing, isn't it?
Stelio,
Yes.
in a cesarean delivery, the cervix always have to dilate or no? I mean,
Not necessarily.
but
We don't dilate the process surface. But usually we do because, again, the monitoring, of course, but that's not, of course, usually, of course, the big problem. Because whether you like it or not, it will resort, of course, to ligation. To dilation, what I mean.
Okay.
But commonly, of course, depending, of course, on the setup, if it's a condition, because of oxytocin, later on is the effect of oxytocin, and the effect, of course, of contraction, because oxytocin will be given, of course, the woman
Right.
after delivery. The purpose of oxytocin, of course, drip after is to prevent cramping.
Right.
If the uterus is cramping, whether, of course, we have full dilation or not, it will lead, of course, into dilation in the basement. So eventually we have dilation. But again, if we, from the start of C-section, do we need, of course, to dilate and face the woman? No.
So in a C-section, everything will be taken out, the baby and the placenta will be taken out surgically. So my question, the contraction of the cervix, how would it close back? Why would it be closed? Because if it wasn't dilated to begin with. Am I making sense?
Do about the effect of your oxytocin.
Yeah.
Again, oxytocin, of course, will help repel, of course, the cervix. It will gonna dilate whether you like it or not because the uterus is cramping. And cervix is just part of the uterus. So if the dilation, again, the one thing is that if the woman, of course, it will be dilated, of course, primarily, not only fully dilated 8 to 10 cm, but at the end, of course, postpartum, they will gonna be openly, of course, fully dilated. Because later on, a C-section, of course, the woman, you still have to monitor, of course, the vagina for the lochia.
That's what I'm kind of.
You think? And women, of course, who have C-section are given always oxytocin to potentiate up to cramp, of course, the uterus. Because you induced one. If you're going to do, of course, C-section, there's no other way, of course, to cause contraction of the uterus after C-section but to give oxytocin drip. Mandatory, if there's no oxytocin, the woman, of course, will die. We're going to bleed, of course, the C-section, of course, incision. You have to contract. And on the process, of course, of giving oxytocin, once the uterus already, of course, contract, of course, it will gonna open up. Whether you like it or not, it will gonna open up. The good thing about it is that you don't enjoy it. If the blood will get coming out, of course, of that one, if it's 4 to 6 cms, it doesn't matter because you didn't endure, of course, your cervix. Okay? The most important thing, of course, with the cervix is that we don't allow vaginal delivery with full dilation because, again, we'll destroy it. And destruction of that could cause bleeding, not only your immediate, of course, concern, but also, of course, your concerns will be future reproduction. So vaginal bleeding, placenta previa, hospitalization, fetal monitor, IV blood administration, because again, we have to replace the blood. If the woman got hemorrhaged, then we have, of course, to put our RBC, okay, replacement. Possible C-section, vaginal packing, in emergency infant resuscitation should be there. Because sometimes, it could be allowed less than 30%. We could do vaginal packing to push pressures, of course, on the cervix to prevent, of course, to make closure, of course, of the blood. Okay? So ultrasonography. Another one is that SVE. Anybody who is, of course, pregnant who comes to the clinic for vaginal spotting, again, the rule will be do not attempt to insert your gloved fingers. Of course, we don't insert our bare fingers. Oh, of course, I won't. Okay, I have the gloves first if I will do SBE. That's why I call it like SBE vaginal. Because of the chance that you could dislodge, if it could be placenta previa, because the placenta previa presentation will be spotting or bleeding, vaginal bleeding, of course. And again, that's why, as a general rule, anybody who comes, of course, to the ER or the clinic, of course, with a vaginal bleeding or spotting, okay, we do not do sterile vaginal examination. Why? If we were going to do, we could cause pressure on the placenta and cause total dislodgement, and now, here we go, we create a massive problem and bleeding, okay? So that's why SVE is only done, of course, with the doctor. By a doctor, not only the doctor, where? In OR, just in case bleeding will occur. We could do right away because we don't want, of course, if bleeding occurs and there's spontaneous abruption, separation of the placenta, we cannot allow it to happen or else the baby will die. So while there's bleeding, we have to open up, of course, the abdomen to remove the baby out before complete separation of the placenta. In that time, we could deliver the placenta out, of course, vaginally, whichever. Observe the mother carefully for hemorrhage following, of course, the placenta previous delivery. Bleeding continues, severe attempts, of course, to control are unsuccessful. This is what I'm talking about. Emergency hysterectomy, removal of the entire uterus, of course, will be warranted. Okay. Abruption placenta, meaning to say premature separation of the placenta before the baby comes out. This is one of the great emergency. Usually develops after 20 weeks of gestation because again, it develops before 20 weeks of gestation. It is just typical abortion. Okay? Often occurs without labor. There's no contraction. It is just possible injury, trauma, something like that one. Predisposing factors will be your hypertension. And pregnancy, of course, and preeclampsia. Okay? Abruption placenta, it will be the cause of placenta. The only thing is that not only, sometimes it's not 100%, but the more of the placenta is separated, the more, of course, that there might be bleeding, and the more, of course, the reduced circulation to the baby. Substance abuse, women who are grand multiparous, meaning to say pregnancy after the 5th time. That's a grand multipara. A grand multiparty, meaning to say has given birth at least, of course, 5 times. Numerous abortion and stillbirths. Okay, before. Physical trauma, just like motor vehicular accident, pressure in that one. Common cause, of course, of stillbirth as well. Why stillbirth? Because again, the woman didn't know that she got, of course, abruption placenta. It's too late, of course, to save the baby because the baby is dead already. Okay? So diagnosis, bleeding, the result may be apparent or hidden. Apparent, it might be, of course, down, of course, in the vagina. Bleeding externally visible, often dark, uterus becomes tender, rigid. This is just like, of course, your appendectomy. The abdomen becomes rigid. The only thing for that one is that commonly, if there's abruption placenta, of course, becomes rigid. If you feel on that one, it is very, very tough or rigid. Okay. Symptoms of maternal shock may occur, drop in vital signs, as well as like that one. Fetal movement may increase or decrease. Increase or decrease. Increase by more than 60, decrease below 100. Equals fetal distress. Okay? Extreme pain or rising of the uterus fundus indicate, of course, bleeding and pulling behind. We call it one retroplacental hemorrhage, behind, of course, the placenta, or we call it one concealed bleeding. Okay? So abruption placenta, bleeding into the muscles could be precipitous labor, meaning to say the labor is less than 3 hours. Again, labor and delivery less than 3 hours is not good. Because again, why? There's a lot of injury to the mother and a lot of injury to the baby. Okay? Loss of uterine tone atony, meaning to say the uterus does not contract anymore. Oliguria leading to acute renal failure. Another one, disseminated intravascular coagulation. It could lead, of course, to maternal death. Any DIC, so usually, DIC, a lot of people, of course, never survive DIC. Okay? So dangerous to the fetus, anemia, anoxia, and eventually death because there is no oxygen. So what time is it? 8:06. You have a lot of questions, so I'm delayed. So, but I'm happy to answer all those. Gosh, 78 of 171. I have almost 100 slides left. Yeah, you see that one? Well, I am only on 78. So I have 78 to 171.
Friday we have class with you.
No, I cannot serve you with that.